like that. Everybody loves it. Awesome. Well, good morning. My name's Matt Wallett. Thank you for joining us today. We're going to run through the agenda first, and then we'll do some brief introductions for everybody. Normally, well, in a non-webinar capacity, we'd walk around and actually greet each other, but we're not going to do that because that's a whole name and shame thing, isn't it? And we'll be here for days. Doris Ann's going to walk through the competition law initially. We're then going to move on to Craig, who's going to talk to us about the digital challenges with COVID-19. So specifics around all those challenges, and Craig hopefully is going to get some feedback from that, and hopefully maybe that might develop some objectives off the back of it, who knows. We're then going to move on to reviewing some of the objectives identified from the last meeting. So we've collated all that information. We're going to go through and show you all that. I think we've got quite a few names from the last meeting, so hopefully it should be of some relevance. For those that are new, please feel free, ask questions. I can't stress it enough. Ask questions, feed it back. It's a two-way meeting. This isn't a one-to-many webinar, that's for sure. We've chosen to use Zoom because we want to get that feedback and try and make it as like for like as it was in the first meeting, really. It's more of an open discussion. We need to understand with the DWP, as it's a new working party, what those challenges are, what's the low-hanging fruit, what are those changes. We know in the IT market in general, especially in healthcare, how agile everything is, especially with COVID going on at the moment. We need to know what's changing from you guys and what challenges you are facing. I've got my own opinions, but ultimately it's not my show. it's your show at the end of the day. We're then going to have a break, about 15 minutes or so, hopefully, and then we'll move on to reviewing and building on those outputs. So I know some of us may have seen filtered around between this meeting and the next meeting. We've kind of distributed those objectives and separated them, etc. So we're kind of building out those outputs and actually deciding on ownership and the objectives, who's going to get those, what are we going to actually get to the end of, because what we don't want with the DWP, I can imagine we're going to get to a position where we're going to have 50 different objectives, but none of them sorted. And we don't want to get in that position. We want to make sure that we've got a few low-hanging fruit that we can just quickly sort. And I think a lot of them are, at the end of the day, a lot of them are issues we can easily fix. And then the last point we're going to touch on is speakers. We spoke about it briefly last meeting. It's kind of, we haven't got, obviously other than Craig, who's going to talk to us about the COVID-19 stuff. Sorry, Craig. But we want to keep going with that one speaker every meeting that's relevant to you guys. And I didn't want to bring someone in that's just going to talk high-level stuff. I wanted to kind of get some information from you guys as the membership to try and understand what would you see as value, which is related to the DWP, you know, from our objectives. So we can talk about that.
Input is crucial. I mean, Matt and I talked about this again the other day, and we emphasised at the first one that as much as we've got an interest in this, obviously why we're involved as chair and vice chair, it needs to, the membership needs to feed in what kind of speakers they want, because otherwise it becomes a bit self-serving. And, you know, I've got my thoughts on some speakers and Matt's got some thoughts. They're all great ideas, but unless they're relevant to you, they're obviously not. You know, so if you've got suggestions and you want to bring something to the party, and I'm all for, and we've had it in other working parties before, that you know, 1 month it may be Matt's suggestion, another month is my suggestion, another month it could be anyone's suggestion. You know, Daniel might have an idea about somebody who wants to bring to the party, and that's great. And that's all relevant, because a lot of the time we don't know what we don't know. So if you don't suggest a speaker, there's maybe a topic or a person or a concept we haven't even conceived of yet, we've thought of. So feel free to put as much as you can into the pot, because without the membership involved, this working party is kind of worthless.
Yeah, no, completely agree, Craig. Completely agree. Okay, so a little bit about myself. You probably guys from the last meeting will be familiar with the first few slides, but we figured that it's going to be a change of people on every meeting, really. You're going to have a change of 10 or so people each time. So I think it's best that we touch on who we are, what we're trying to achieve from the group, etc. So as I said, my name's Matt. I've worked in IT probably for about 15 years now, roughly. It ever increases. I'm never going to change the slide, so it doesn't make me feel old. Started work in the NHS, progressed from kind of the help desk and moved up kind of in pure IT land. I then moved to Sysmex about 5 years ago, came in as a product specialist, and kind of learned the science from the ground up. So did all the IT, had all the IT background, and they figured in Sysmex they took a bit of a risk with me, I think, and taught me the science from the ground up, and figured it would be easier to teach the IT guy science rather than the science guy IT. I don't know, might be some contest out there, who knows. I think it worked quite well. I quite enjoyed it. I think I had an affinity with it, which was quite nice, and it was a good change from the IT. Progressed in the IT manager role about 3 years. And then, yeah, I've currently moved back into my internal IT role just because of personal circumstance, but it's a great dynamic understanding both sides of the business. I think it lends itself to supporting the healthcare and trying to bridge that communication gap that we have between the NHS. And I know me and Daniel have discussed about it briefly. It's having that gap analysis between communicating science to the IT guys and making them know the importance of what we need to get into the labs and get it working and things like that. So it's quite helpful. I'll hand over to Craig to give his introduction.
Yeah, brief one for me. I'll keep it very brief. You don't want to hear about me. My involvement is purely commercial, so I've never been involved in the IT side of the business from a hands-on perspective. All my experience of informatics and IT have always been purely commercial, sales marketing driven, then some direct sales experience and sales management experience of it. I've always been involved in IVD, really, from the late 90s right through till moving away from the IVD sector in 2014. Worked as a consultant primarily in healthcare informatics, cardiology, and angiography, those sort of areas, and radiology and medical devices. Then came back into IVD with Bio-Rad as sales manager almost 3 years ago now. Feels like it was, sometimes it was yesterday, and other times it feels like it was eons ago. And then what's happening that day. And my interest is purely commercial. And I think we said before that Matt and I come in this from different angles. We believe gives it a good dynamic because we've both got different perspectives. We probably even each other out. You know, if I'm not being techie enough, Matt gives me a kick, and if he's not being commercial enough, likewise the other way around. But we tend to meet in the middle on most things anyway. So that's me. And enough about me, I'm sure.
Awesome. Thank you, Craig. Okay, so objectives, again, similar slides from the introduction part is the similar slides from the last meeting, but I think it's key that we need to understand what we want to get from this group. I want to be able to overcome those big challenges that we face between healthcare and IT. I think some of the big ones that we mention all the time, and again, these are some of the priority objectives we'll talk about later, but the Windows 7 end of life, it's a big thing at the moment, big talking point as part of contracts. That standardized connectivity to the NHS across the IVD market potentially. You've got HSCN access, you've got VPN access, you've got all the different things in that bucket, and it is a leaky bucket. Cybersecurity frameworks, we want to overcome those, and we want to try and get that standardized level of security amongst us and the NHS. I know the NHS is certainly pushing it at the moment. And clarification of those grey areas, and those grey areas, those big things like IVDR and software as an IVDR, we talk about it all the time. It's like taboo. This is what this group's all about. We want to try and overcome and make those grey areas less grey. I don't think we'll ever make it black and white. I think that's an unrealistic objective, but we want to make them less grey, certainly between our markets, certainly within our membership at least. What we'd like to get from the group, I think it's important, especially even in this kind of capacity with webinars and things. I think it's important that you guys all feel like you've got a voice. You're not here just to listen. What I'll try and do, I'll go through the rules of the webinar in a second, the code of conduct, as it were. But essentially, I'll try and answer questions where we can. If you stick the hand up, we'll try and notice that. I'm first time I played with Zoom, so I don't know how easily I see the hand go up, but I'll try my best to. We'll certainly answer the questions at the end. But we'll go through, and if you collate the questions in the chat, we'll work through them at the end, as in the concluding remarks, and we'll go through all that. But ultimately, I want to get things done. I think between me and Craig, certainly, we want to make sure there's an output from the group. It would be very easy to go into a group where we're just delivering information. And I think in the IT and DWP area, I think we're not going to be in that position. Not if we don't want to. I think there's a lot of things we can get done that don't exist right now. And yeah, as I said, just to really touch on it, I'd like us all to contribute. use cases, speaker examples, your experience. It's not just me and Craig in all this. You know, we come at it like Craig said, from different angles, but ultimately you guys understand your issues, and it's important if we talk about them and try and understand them, because we might come at it from different angles. So, rules of engagement, as it were. Ask a question, use the hands up function within Zoom. If you've not used Zoom before, it's quite handy. We should see it pop up on the screen. I can see already there's 3 chats in there. So that's really good. Let's go, click forward. Please ensure the mics are muted, just the feedback really. We'll mute everybody if needed, but unmute if you need, obviously if you're asking a question, and feel free to jump in if you need to jump in. You know, ask a question throughout. I don't mind, personally, I don't mind being interrupted. As long as it's not 7 of us interrupting, let's take it in times. And just to let you guys know, meeting will be recorded. You've probably seen it in the top left, but Nat's recording the meeting, and links to the recording will be sent out afterwards, just in case there's anybody you want to pass it on to, etc., which could be quite useful. Okay, on that note, I'll hand over to Doris Ann, who will talk to you about competition law.
Sorry, I was working on Teams before I joined this, and so microphone's in a different place. Good morning, everyone. Just a brief reminder, because working like this is slightly different to when we're all together. But like anything to do with getting members together in BIVDA, we've got to remember we're covered by competition law. So please keep this in mind when you make any comments or ask any questions, that we need to think about not going into the specifics of any one tender, talking about pricing or any way that could be construed as fixing the market. Obviously, any chats between yourselves can be private, so we can't see those, but please, you know, be careful not to overstep the bounds of competition law. You should have had the guidance sent out with you, and we can always make that available to anyone who doesn't have it to hand and would like it. So if anyone needs it, please put a message in chat, and then we can get it emailed over to you. Really, that's it, I think. I need to write myself a script for virtual meetings for competition law, but it's just a health warning that it's still in place regardless if not meeting in person. Thank you.
Thanks, Doris Ann. I just looking at the chat myself just before I continue on to Craig, from Kevin. How do we submit suggestions? Can they be visible to all, perhaps in a list? I think we'll work on the chat this time around. I think, yeah, it's a fairly good comment. So ultimately, part of this presentation, when we work through, we're going to be breaking out into some groups, into breakout groups. Now that could go horribly wrong, but hopefully it works fine. We have tested it once. You know, typical software test. So we'll go out into the breakout groups where we'll answer some questions, and we'll come and feed that back centrally, so we can feed it back directly on the presentations. But in terms of questions, I think if we just use the question chat at the moment, or you're welcome, if it's quiet, unmute yourself, fire a question in, and I'll just stop chatting myself. Craig, do you mind being interrupted like that? You know, operating in the same sort of way?
Standard for me.
Yep, just being interrupted, yeah.
Yeah.
So
I think you're going to do that on occasion, just in case.
So I think code of conduct, guys, I think it's fine. If you want to jump in, just unmute yourself. I think if we get chaos, then we'll just do a mute all, and then we'll go round it, round table style. I think there's no wrong answer here, so don't feel shy in terms of asking a question. I certainly won't feel it's rude. So go ahead, or ask a question in the chat. That's no problem at all, and we'll try and touch on those midway through. Awesome. On that note,
share screen.
Yes. Stop sharing. Go for it.
See if it works. Well, it's asking me to a privacy setting. In a minute.
You tested it. We definitely tested it, guys.
We did. We didn't. There you go. Right, should all be good. So another go. Aha. Right, so As Matt said, it's largely about trying to find some content and trying to invoke conversation. So what I tried to do with this really is I've had my head in various kind of e-health forums and webinars, and I'm sure other people have within the group too. And the question was, could I find anything specific to IVDs in terms of e-health? The answer is no, I couldn't. And it kind of paramounts why we've got this group together in the first place, because there is no real agenda for e-health innovation, for informatics in the IVD space, which is, part of the why that is behind this group as a bit of a brainchild. So I've put together something which is more of a topic of conversation, I think, really, and it runs through some information I picked up on various webinars and put together some very, very good webinars are there if you want them. Some that ran our webinar the other week that we're thinking about getting on as a speaker, a guy called Omar Butt, who's based at Imperial, and his role there is to manage the space between companies that have the ability to commercialize, let's call it stuff, for want of a better term, because it could be anything, and also the people who are the brains within the healthcare sector, within the academia sector, that don't have the commercial acumen. So he's probably someone we're thinking about bringing along at some point as a speaker to hit this space. But he was running a webinar. I thought, I'll be interested to join that, to see what's said. And I've linked in some other stuff that I've done on other meetings. So I just got Matt's image in the middle of my presenting screen. I'm just going to move you, Matt. So this is all around kind of e-health in COVID-19 and what's happened and why it's happened. So why has innovation been so fast in this whole scenario? The technology's always been there to a greater or lesser extent, and we'll explore some of them now. We're using one now. Zoom's been around for a long time. It's never been used the capacity it is now, and I'll talk about Zoom a bit in a while. But the standard phrase of necessity has become a mother of all inventions. Well, that's true. We've needed to do things remotely. We've needed to work remotely, and that's not just for us having to work as commercial organisations. Doris Ann, I know, has been on more webinars than she probably cares to count. There's been so many. Every day Doris Ann's about 3 or 4 with different hats on. But we're all in a similar boat. But then you go into the healthcare sector, and you've got all the triage appointments that are not happening in person because of social distancing. And that's not just the UK, that's global. So we've had to find ways of working. And it's been trying to utilize stuff which is already there in some capacity, and then trying to bring things into to make that experience much more immersive, much more involved. So thinking about consultants doing outpatient reviews. And outpatients is key. We'll come back to that later. I'm going to keep mentioning it a few times because it's food for thought. But they've had to use various different ways and means to see patients, triage patients, provide feedback. It's not really been about technology. I said before, the technology's been there. What it's needed is been the people who need to find solutions to bring those various bits of technology together, provide the solution for them. And enhancing care with technology become an absolutely essential part of day-to-day life. In terms of, and again, I'll use cardiology as an example later because it's one of the prominent ones that I've come across. Oh, have I gone on too far? No. So there's a lot of factors of poor adoption of technology in healthcare, and we're talking about the healthcare setting. I should caveat at this point, this is not about IVD. So nothing around any of these conversations are IVD specific. So if you think I'm talking about something who's IVD specific, I'm not. This is just a broad conversation around IT technologies and usage thereof in the healthcare sector. Within every conversation involvement or bringing IT platforms to market or solutions to market, there's always 3 parties. It's always the patient. The patient is always the benefiting party. So the decision has to be made around whether the patient's going to have a benefit. And ultimately, do patients want to have that experience? Because if a patient certainly doesn't want to have that experience of an e-health technology, they won't adopt it, and therefore there's no use bringing it to market. There is the customer. So from our perspective, it's the laboratory services department, or it's IT department, or in general, it's the healthcare setting. If they're not keen on adopting something, then that won't work. And as commercial organizations, I think we've all been guilty to some way or another, whether it's as individuals or whether it's organizations we know, have a piece of tech that you don't bring to market because you don't believe the market wants it, or you don't feel the market's ready for it. And the fact is, if any one of those parties is not keen or is fearful of committing to pushing the technology, it just won't happen. I mentioned the patient side of it, the customer side of it as well, and again from the commercial side. It's generally born out of fear. Will it succeed? Will it work? Will it become a benefit? And we tend to stick to what has been, we use this phrase a lot now, is the normal, in inverted commas. Necessity, however, has removed that fear. We've had to make adoptions. There's been no other choice but to adopt stuff. Adopt and adapt has kind of been a bit the mantra about the e-health space. And it's accelerated the acceptance of, we'll call it acceleration. I hate using the same word in one sentence twice, but we had to do it to make this work. Acceptance of an accelerated process has become accepted within healthcare in general, whether it be talk about testing or remote patient reviews or file sharing. So what have been the drivers? Well, I mentioned the need for remote care. And we give an example is it's one of a few webinars I've been on called Zoom++. Matt and I and Nat were talking about the other day in terms of using Zoom as a platform in itself is great for seeing a patient. Okay, I get the feedback from consultants, clinicians that they don't get the interaction with their patients. They can't see all of the contraindicators for a condition or something they use for a diagnosis in a face-to-face visit, but it's good enough as long as there's other stuff to supplement it. And I mentioned angiography for a reason. There have been solutions around for a long time around digital image transfer and sharing. The Dutch have a completely privatized system for sharing angiography images. And if you're not familiar with angiography, they're very high resolution, moving short videos, effectively. And they are pretty high kind of gigabyte files in terms of sharing. There's also been the remote issue of testing. Now we know about the remote issues of diagnostic tests. We know about that because we're involved in it from a business perspective. But trying to put all these things together are difficult. So Zoom++ has been the main driver. Most people use Zoom. Probably most of the big success stories of anything about COVID-19 has been the rise of Zoom, or the fall in some people's eyes. But using multiple technologies to deliver care is pretty key. And there's new technologies that are providing more immersive experiences. And something I'd like to discuss a bit later is that of value? Do we want to see new platforms to help us to provide care solutions? Can these immersive technologies help us as organizations sell to the healthcare sector, delivering presentations? And again, I would bring you into the conversation here, Matt, but I don't know how you feel about this. But in terms of this working party, there is maybe a rationale to say, can we help identify tools that you can use as commercial organizations to sell to your customer base? If we can, is that a value?
Yeah, I think I think ultimately it is. I mean, I think the big point that you make there is the acceleration of change and the acceleration of acceptance. I think that's the big key point out of all of this. We talked in the last meeting about one of the points that just comes to mind is the rapid software change. I think it was rapid software change cycles, something like that. I think it's called that. I imagine they're not having much of a problem now. I don't know. Are they still having those types of issues where they're still struggling to get those changes implemented within the NHS sector, the health sector in general? Sorry, I think no is probably going to be the short answer. But the problem, that the backlash that comes back to that is the resourcing side of it, Craig, isn't it? People might be you might be getting accelerated change, but you might not be getting the resource behind it to actually validate and get it through.
Exactly. And resources is key, and I'm going to mention that in a little while. But you're absolutely right. I mean, again, Matt and I will talk about this kind of in a sidebar later, but there's something we may offer you. We'll maybe send a note out in terms of, are you keen on seeing technologies that could help you? We're not party to any technologies like that. So if I see something of value and think, hey, the digital working party can benefit from this piece of knowledge. So we'll revisit that another time. Another thing which has been key, and this is particularly key for something I'm involved with, is sample collection. GDPR around sample collection. The MHRA issued guidance in terms of remote testing for COVID-19, whether it be antibodies or PCR, using capillary collection kits or remote collection kits. It's the MHRA guidance. It wasn't really about the kit. It talked about the kit had to be CIVD marked. Well, nearly all of us in the marketplace that have got tests are CIVD marked. So the issue wasn't around the kit, it was around how the samples collected. There aren't many CIVD marked collection kits that there kind of are now. But the big issue is around GDPR, because of course you've got private testing labs involved in collecting patient data. How do they do that? Well, there's a way around it, and I'm not an expert in GDPR, so I'm not going to even dream about getting into that space. But I do know for a fact that some of the roadblocks that were an issue with GDPR, the providers or the service providers or the service users have found ways to enable those roadblocks. So things that used to be an issue, Matt's touched on one as well there. Things that used to be issues or blockers are no longer blockers because we've had to find ways through them and make them work. I know I've got country leadership, but in terms of what I guess I do really, it didn't really need to be country, but we'll use the country as a catch-all. The healthcare sector leadership has struggled with the processes. I know we talked about this in other working parties. I mean, this procurement working party focused on, and Helen did some of the presentations on it on the last meeting, was about how we've struggled with procurements. You know, and there was a webinar from Cameron McKenna too about how procurements, some of the procurement processes are being kind of waived. You know, how many extensions have you seen that have issued VEET notice because there's been a VEET notice because we can't do an official tender, so we can continue an existing framework? Daniel's got the hand up. Daniel, do you want to ask something now?
Just a quick one. So the ICO a bit of guidance around COVID-19 and the use case for data and the processing of data. So what I was just going to say is that the actual ICO have been on this, and basically there is legal basis within the GDPR Data Protection Act which supports the processing of data by these third parties. Yeah. And a lot of it could be public interest, various other things. But what I'm saying is they've given quite a good use guide and support around the implications of the two. And that's all we're saying. It's on their website.
Okay, that's good to know. If you've got any links to it, because I'm sure most of us might not have it, if you could share it, that would be great.
Yeah, I'm just trying to figure out how to send to all. At the moment, I can only seem to send to Matt in the chat, and I don't think I want to just keep bombarding Matt with everything. So I'm just trying to figure out how to send to everybody.
To be honest, Daniel, if you want to send it to me, if you can't find it out, just send it to me and I'll filter it over to Nat so everybody can get it sent out after the meeting. It's not a problem.
All right, cheers, mate.
Thanks, Daniel.
So back to what I was saying, the leadership has been a struggle in terms of procurement. So what's happened is stuff has been fast-tracked. Not that it's been uncompliant, it's just happened faster because it's needed to have happened faster. And if we had the standard process of getting new innovations to market, it would have taken far too long. In terms of the involvement that some of the BIVDA members have had with the Crowdicity platform. You know, that's been innovative in terms of new thoughts and new ideas accessible to the marketplace. PR has been a big factor. Companies are getting a lot of airtime in terms of finding solutions. And again, this is not IVD, this is in general, so this is much broader. We tend to focus on IVD is the world we live in, so therefore it's all that matters. But airtime has been key in terms of assisting stuff, and we've seen it, whether it's in the US or other countries, that if something gets promoted, it tends to get used and it gets recognised. Public facing exposure has been essential, and again, this comes from the webinar that Omar was running. And then what's happening is the smaller innovators that know exactly what technology to produce, those guys that work in universities have sometimes struggled. We've had some really good innovation from like Francis Crick and from Oxford, where they have managed to get aligning some commercial support to bring their solutions to market, which has been great. And that's something I think we need to see continuing. So what happens next is key, really, because in this situation, it's been great to see innovation from all companies, large, small, and individual innovators bringing stuff to market. It's been fantastic. And what nobody wants to see is that pace of innovation stop, because if we stop the innovation, we're gonna limit what we can bring to market and how we can do it and how we can make a difference, certainly as a country and as a sector. So we need to maintain that acceptance of adoption. What we need, though, is cleaner process of adoption with a focus on quality and looking past a wow factor. So not every solution that's come to market because it's had a wow factor has been key. And this is something that was said on the webinar the other day, that the experts in the delivery of the processes and the products, not necessarily the ones that are getting to the top. It's the ones that are making the most noise the quickest. So once we start looking past that wow factor, we're going to get to the nuts and bolts of what's really, you know, people are close to patient care, but bringing some technology. Daniel, do you want to jump in? Daniel, got your hand up. Is that a question or would you need the loo? I think you're on mute. I can't hear you.
Basically, I said I didn't lower it from last time.
Ah, okay, fine. So patient value has got to be central, because we need to be focused on clinical impact, efficiencies and time saving. They are buzzwords, I know that, and we've all used them in tenders and so on and so forth. But it's really key that e-health innovations need to be the ones that are driving the difference. And I'll get onto why shortly. So trends in healthcare, I mean, what we're going to see next, we are going to see the rise of telehealth, but not telehealth as we saw maybe 5, 8 to 10 years ago. We're talking about real, I'll call it telehealth rather than telemedicine, because it's not telemedicine. All right? We've all seen the HbA1c monitoring patches. I mean, for my sins, I enjoy watching US news once our news gets kind of repetitive in the evening, and there's loads of adverts on there about wearable patches, and we've all seen people wearing them. So yes, that's great. But in real telehealth, delivering health via video links, I mentioned the Zoom++ or evolutions on from that, we are going to have to use something while we're dealing with the COVID-19 recovery. We can imagine there is a huge patient backlog of general patient care. Lots of us involved in BIVDA are involved in the core laboratory space. You know, some of the key members are involved in the core laboratory space. The workload in that has been hammered, the general workload, and in some cases during the kind of second quarter to 90% less than you'd have expected. We're talking about people with diabetes not having blood tests done the way they used to have them done, and so on. And there was the big issue about the deferral of laboratory tests that came through from government. You know, some testing was seen as being not essential for now because there was an emergency situation. So we're clearing that backlog of patient care, whether it's oncology reviews or orthopedic meetings or orthopedic assessments. There needs to be a need for social distancing. How are we going to use e-health to manage them in a different manner? And there needs to be a bit of a culture change. I mentioned before that the providers of care have got to make some serious changes. Although we've got some whiz-bang technology, some great solutions, the models of hospitals are not really different to the way they've been in the 1940s. Right, you go to a hospital and you use an e-check-in desk, and then you sit in outpatients for an hour, which is the same as it was like in the 1940s. Or waiting time probably less because there's less people using the NHS, for example. But the models of care haven't really changed. And I think what we've seen now is there are attitudes that have changed because they've needed to towards acceptance of innovation. It's almost a case of the ones that didn't want to have now gone, we don't have a choice. We have to adopt something, no problem. So that's been interesting. And this is my last slide. I usually finish with a nice summary and some concluding comments, but I don't want to. I want to provoke a bit of discussion. And this, I've mentioned outpatients a few times, just something to think on in terms of the parameters of how everybody within healthcare and in diagnostics fits into the care pathway. Do we need outpatients? It's quite a key question. Do we need, from a health perspective, a patient experience perspective, do we need umpteen hundreds of people go into a hospital just to sit in the waiting room? And if you start exploring that outpatients question, what changes can the healthcare sector bring, including the diagnostics industry, to market to revolutionize that space? It doesn't have to be something we discuss now, but of course you can if anyone's got any comments on it. But it's just food for thought. And if anyone's got any comments they want to raise afterwards, or we extrapolate it, I just want to leave it hanging. That's all I've got to say. Thanks. It's not often I run out of things to say, but I just want to leave it hanging in the air and just see what people's thoughts are on some of those messages.
No, I think it's a good point, Craig. Really good points raised. Has anybody got any questions for Craig?
Or statements, comments, criticisms?
Or statements, yeah. Well, how about I throw a question out there to everybody then? I'd be intrigued to hear. I mean, everybody's got their own story about how work. And me and Daniel were talking about it when he first came in. You know, how is COVID-19 really affecting your working lifestyles, your business, etc. And kind of the challenges I think have changed somewhat. They've evolved. What were our challenges pre-March? Certainly, I can speak for myself. They're not my challenges now. And as Craig's put out there, the changes that we're putting out there, I've certainly seen the requests for change from the NHS to us as a provider increase tenfold in terms of what they need to make things work. I think Kevin, you messaged me directly. I'm going to call you out here if you don't mind, Kevin. You messaged me directly about the rapid software change, and you said about the FDA. I'm surprised by that message that nothing's changed, especially in light of recent dilemmas. Are you able to elaborate on it?
No, this is. Am I muted, or can you hear
No,
me?
we can hear you. We can
Loud
hear
and
you.
clear.
No, this was just around perhaps a future topic that under the IVDR, as we transition to that, as a rapid software development company, we're involved in genomic analysis. So we're keeping up with the new technologies. We're adding features all the time on a quarterly basis. And I'm looking at having to submit a technical file to a notified body 4 times a year for review. And I just think that's a massive burden that we could do without. It's going to slow everything down. It's going to perhaps not destroy our innovation, but it's certainly going to hamper it. And so I don't know what can be done about it. As I said in that comment, the FDA are looking to do approval of trusted companies, trusted entities. So they're kind of a bit like a 15189 type lab approvals. You know, it's.
And if you fall into that, Kevin, are you saying that if you come under that approval, that the changes get pushed through quicker because you're an approved company with a specific ISO standard? Is that kind of what you mean?
So you see, I think what they're looking at doing is more or less they'll trust the company to do the innovation. They assess the company, and then they can carry on evolving rapidly because they know they'll be doing the right thing. You know, historically the issue, I suppose, with medical devices and the whole thing around the notified bodies and certifications is because things were going awry, people were dying and getting injured. So, but I think, you know, again, we've come a long way since then. So,
I think linking directly onto Craig's presentation really, and to this, you've got ISO 27001 out there. Certain businesses are obviously accredited to that. And there's already something out there. Yeah. You are as well. So yes. I mean, you'll know from having that accreditation then that if you fall within that bucket, then you know the NHS agrees that you have certain processes in place, certain security principles in place, and that you only need to. The quick example I can think off the cuff is the Cyber Essentials process. Is that you don't have to answer 70% of the questions because you are considered to have ISO 27001.
Quite right.
So taking that 15189, this for me, there feels like there's something we could do as BIVDA is essentially help you guys bridge that gap around. If you've got that ISO accreditation, then you should fall into that approved body. You know, it might be a little bit more than just having the accreditation. You might have to go through certain checks and things like that. But like you say, I mean, what would be the turnaround times that you'd be expecting? I imagine once a month, or is it ad hoc? Are you thinking with your own change cycles?
Our release cycle is 4 times a year, quarterly. So there's always going to be a major feature in there. So we're always going to have to be resubmitting our technical file to the notified body.
So I guess what I'm asking for, what are you looking for in terms of to improve that process? So you release 4 times a year. I'm guessing you're not able to. Your barrier at the moment is you're not with the NHS. You're not able to, essentially.
Well, we're not just with the NHS. I mean, we're marketing worldwide. So, you know, I'm registered with NHS Digital. We are registered with NHS Digital. So we've got all those accreditations. And we're also ISO 13485 certified as well. So, but nevertheless, as a CE marked product, we will have to submit the technical file each time, and it's just a huge burden.
Okay. Well, I've got that down on our objectives list. So it's something we will be addressing, I think, for you guys. I think it's probably this could become a low-hanging fruit, and especially with the current situation at hand, with the acceptance of change being there, I think there's a lot of things we could potentially push through. Not just this one, to be honest. So
I think so. Nigel's on the call from. He's looking now. He's panicking. Nigel and I were talking about it yesterday because we were talking about this exact thing. Can you just remind, well, for my sake, especially because you know what I'm like, but also other people on the call, how many questions that some of those ISO standards mitigate from the toolkit?
I think
the HSCN toolkit.
Yeah, I think it's 40. So there's 40 for the ISO standard, and there's 40 for the Cyber Security Essentials, which then leaves the 40 remaining that you have to respond to. So there's 120 in total if you don't have those 2 standards.
Also, it makes the 27001 almost cost effective, doesn't it?
Yeah. Especially when you factor the cost of consultants to help you complete it.
And I think the issue we found is, being an American company, we have an equivalent certification in the States, which covers the company globally, but NHS Digital do not recognise that as a standard. So they it's not equivalent in their eyes to the cyber security essentials.
What's that? The ISO side?
No, the sort of it's a similar. I totally forgot the name of it. It's a similar standard to the cyber security essentials, but is it HIPAA
and high-tech compliance?
Could well be, yes, could well be that.
Sorry, it's Dan here. Remembering that cybersecurity essentials are control standard, ISO is an information security management system standard, and HIPAA is in a specific American legislation. Yeah, so they're three different things. So just to provide a bit of clarity, that HIPAA is all around about the medical healthcare system and getting your data out when it comes to America, not necessarily around the security of data on systems and platforms. Yeah, because they don't consider privacy. So it's when you start quoting regulations and looking at standards, you need to look at where they come from to then whether or not you should be implementing it and meeting them. Yeah,
I mean, there's massive overlap with all of them anyway, isn't it? I mean, certainly I don't know the HIP standard, to be fair, but the ISO and Cyber Essentials Plus, as an example, there's massive overlap anyway.
NIST is a really good one because that's a recognised vulnerability standard, and that's what people do use. But what I'm just trying to bring feedback to say is that that's why there's quite a lot of confusion there, and individual regulators, individual countries pick out the standards they think meets rest for their regulatory framework and their legal requirements.
From our perspective, at least the HSCN requirements allow you to say, if you've got this standard, then you don't have to answer these next 40 questions, which is a benefit. We could do with more of that, really. We really could.
Yeah, I think sometimes in tenders it'd be quite nice to have that button as well sometimes to say, yeah, that's a good question, rather than go for the same 50, 60 questions repeatedly all the time, yeah?
Don't tell me you guys don't use copy and paste.
No, I review each one individually, don't believe me.
They all word them slightly differently, so you can never get away with copy and paste. Yeah.
Don't get me started on my soapbox of tender library responses.
Awesome.
I was going to say, just make me aware, in response to COVID-19, I was reading an article online about apparently there's going to be there's a concern about cybersecurity vulnerabilities and risks now linked to the massive implementation and integration of change. So what's happened to get the deployment and get all the new systems and operations working, there's been a movement to cloud hosting. And I don't know if you know, but cloud hosting has a different security standard than 2001. So it's a different security platform, different risks, different vulnerabilities. And the concern is now, as all this migration's happened, all these systems are in place, but none of the appropriate controls and vulnerabilities have been considered. So there's now a load of at-risk cloud-hosted systems, especially linked to the data in, data out, APIs and things like that. The reason why I bring it up as a course is if you provide a product to a customer, it's their risk. If you provide a service to the customer, you are bundled in that risk portfolio. So if you're in a virtual space in their cloud infrastructure, you're actually, if you're in an appropriate service agreement, you're actually bound to that risk portfolio too. Yeah.
Yeah, that's a good point, Daniel. It's a good point.
I don't know how we want to, because it's the other thing is we've got quite a lot of we've got lots of different technology stacks going on, technology changes. So it'd be interesting. I don't know if that's something we want to look at, cloud hosting and the impact of that. I know some people have done it, but again,
we certainly could. I mean, we could pull in people that aren't. This is again the value of this working party is we because a lot of this is new to IVD, other sectors are not. In terms of cloud storage and cloud usage, digital imaging is one which has been done for quite a while. You talk about digital slide imaging, for example, even laboratory services. There are the ability to have cloud hosted virtual slide farms, for want of a better term. So we can certainly get other people involved from either diagnostics or from outside of diagnostics, just talk about the principles of cloud hosting, without question. I mean, if we're talking about vertical managed services in IT, the risks don't change whether it's healthcare or banks. It's exactly the same. You talk about there's an awful lot about worries about patient data in terms of having cloud-based managed services or e-records. But then you look at Credit Suisse that process more transactions per day on cloud hosting financial records than the whole of the NHS in one day. And they manage it. So other industries do manage that data, and financial data to me is just as secure as healthcare data.
No, absolutely, and I completely agree. The only thing you have to look at is there's fundamental differences when it comes to insurance and financial data. There's specific legislation built in to support actions, which not necessarily in.
And that's key, isn't it? This space is not very mature. Digital health is not very mature, so you'll see some adoption and some changes from what they use in the financial industry, probably because it's the closest tangible, mature area.
NHS Digital are implementing data lakes and those type of approaches which have been implemented. That's how you can have a transactions at bank and they all talk together and you get able to, you say, process transactions across loads of different bank accounts for loads of different financial institutions without having to worry about APIs and, you know, spending hundreds of thousands, millions of pounds on interface and things like that. So that's all there. It's just we are literally in 1980s and they're in 2020. You know what I mean? It's how we get ourselves there and the journey we go through.
I think ultimately at the moment, the issue we're going to face, and it's going to be the fallout after all of this, is that changes have been made so rapidly in an immature market that we're going to be almost picking up the pieces at the end of it digitally. Excuse the pun and to throw out the word digitally, but I think you guys all know where I mean. But we're going to be putting in the legislations reactively rather than proactively, based on what works and what doesn't work. And I'm personally already seeing it. I think a few nods here on screen. I think you guys are all seeing it in your marketplaces. It's going to be interesting, certainly for sure. It's going to be interesting. Awesome. Is there any other final questions? I'll go silent for a couple of seconds. Perfect. Okay. Well, we'll move on then. Thank you, Craig. The next step is we're going to review the objectives that we've identified from the last meeting. Now, some of you guys weren't in the last meeting, so I might try and flip screens and go all fancy and show you guys what we put together. But it will be swapping screens, so my mouse not working, which is always good. But I'll go over what we've done objectives-wise at the moment. So obviously we've only had one meeting already. We've categorized from that meeting. We took it was an outputs exercise where we took all the objectives and all the problems that you guys face within the digital space, and we kind of put them all into a primary and secondary objectives area, just really from a prior, really to identify that low-hanging fruit so we can get it sorted. Because as I said earlier, initially in the introduction, is that we could very quickly end up with 50 different areas to look at and none of them getting sorted. So I think it's key that we take a small bit at the time rather than just operate in a leaky bucket approach and we start losing things at the bottom. From the last meeting, we come out with 4 primary and 7 secondary objectives. Of the primary objectives, those identified were operating system upgrades. So the big thing, Windows 7 to Windows 10. And I don't think, I mean, please someone jump in and correct me if I'm wrong, but from my perspective, I don't think that's really, other than getting into sites, the COVID-19 situation hasn't really changed the Windows 7 to Windows 10. There's been a flurry, we mentioned it last meeting, I think, around extended security updates. Mm-hmm. Now, I think there's been some clarity around that, especially on Microsoft's side, because there was so many acronyms being thrown about on Microsoft's side. It was hard to understand what was a extended security update and what was extended support and where did it all fall into and what date it was. I'm going to throw the question out there. Is there anybody, it's probably easy, is there anybody that doesn't understand what an ESU or an extended security update is? Because I think it's probably worth some clarification whilst we talk about that. No? Awesome. Okay. So extended security updates are being sold now for the next 3 years by Microsoft. And ultimately, if you're choosing not to, or if the customer isn't choosing to, depending on who's paying, because that's another political drama, isn't it? But ultimately, if you don't pay for the year 1 and you leave it to the 3rd year, you will have to pay for year 1 and year 2 and year 3. So it's important to note that from a cost point of view. And also around the whole processes with Windows 7 to Windows 10. Ultimately, the whole CE marking comes into play. There's a whole different life cycle with Windows 10. Those that don't know, you've got different branches of Windows 10 compared to Windows 7. So Windows 7 just had an end of life. Windows 10 now has revisions, almost update revisions that you meet up to, and they have their own individual life cycles. So I think we sent it out as part of the actions last meeting, but you probably, if you guys had a chance to look through that website, there's a lot of different end dates within that life cycle, and it's important to capture that I think, within your contracts and things like that, just to help understand and define who's responsible for keeping it within support and things like that. And then the other objective was the NHSI digital alignment, and I think what the point on that one was, it was, again, using Craig's words, it was a bit of a catch-all with NHS Digital, NHSX, and trying to understand and bridge that alignment between us as an IVD market and the NHSX and digital companies as a whole. You know, what are they bringing out there so we can be ahead of the curve and try and standardize with what they're trying to do and what they're trying to push, and almost be in a position policy-wise to help drive those policies. So the next steps on from that were the decision on the outputs. So I think that's what we need to do as part of this meeting at the end. I think we need to define, I think I see myself and Daniel have certainly added to the kind of the objectives spreadsheet, which I'll show you in just a second. But it's important that everybody gets kind of their opinions on what the outputs are. And I think what the idea would be, what I'd like to see is kind of a harmonized opinion of this is the driven output from this objective. And then we get that piece of work done. I think that's important that we get something out from this group that's going to benefit us all at the end of the day. Ownership, I think, speaks for itself. We'll start defining kind of mini project groups and things like that so we can take that work away and start getting that work done. And what further requirements are needed. Now, I think with the structure that I put up, and I'm open to opinions on this if it can be improved upon, but the kind of primary and secondary, although it says secondary, doesn't mean that it is, I see it as less of a priority. They're probably more long-winded work. But I think naturally that secondary work can become primary. Once we get that low-hanging fruit sorted, we just start working through. And we all feel like we're getting something from this group rather than just turning up, as it were. So I think what I'll do is, before I go on to that slide, I'm going to try and show you that sheet if I can. Hold on.
Subliminal, that, man. Just dropping that slide.
It was, wasn't it?
Image in, yeah.
Trust me, I had to put that wallpaper out back in March. It wasn't a pleasant experience. I got a lot of feedback about how to wash hands, as you can imagine. Right. So this was the sheet that was emailed out. It's just to kind of go overview of the structure. We're not going to go through everything on here, but ultimately it was categorized into two different worksheets, priority and secondary. You can see on here, one of the main things that came out of the group's IT requirements at the R&D phase. So I've just put a bit of summary there as to what that was. I think we all remember pretty much what come out of that. I think we just need some clarity around what they were, so we can all kind of work to the same, sing to the same hymn sheet. There was a digital alignment, as we discussed, the Windows OS upgrade standardization, and then the Windows 7 to Windows 10 contract clarity, which very much overlaps, I think, with this. It's almost one piece of work, but I wanted to make a mention of both, because I think we could probably tackle that as one piece of work to fix it, around the processes of upgrades and what do we need to put in the contracts to try and, again, remove that grey area or make it less grey at least, especially when it comes to core contracts versus managed service contracts and all that kind of side of it. So we've then got the secondary objectives, and Kevin, you'll be pleased to see that one's there, top, ready to go. We captured that from the last one. I think it's something certainly we need to look at as a group, because even though it's predominantly your focus within your market, rapid software release, I think we still have a lot of us around here. I mean, certainly with Sysmex, we certainly have a process with software release and how we cover that within the contract and who's responsible, who's not, how do we get that delivered, what's the testing plan around it, blah, 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 you know, all the rest of it. So I think if we were able to get something in that could almost catch all and help us all, I think that could be beneficial. Capturing IT requirements at the procurement phase, license ownership. I think that was the big one that had some chatter around that. It was understanding, again, between core contracts and managed service contracts around who owns the license versus who owns the hardware, etc. Especially, it's going to become a big thing now, I think, with Windows 10, with the latest operating systems and things like that. So, you know, understanding who's required to do the updates. Digital standards for the startups. I think it's kind of similar to capturing IT requirements for the procurement phase. It's kind of understanding what they are, what the standards are. Internet first. Now, Internet first was mentioned, I think by Daniel, actually, wasn't it? I think you mentioned it last meeting. It's something I hadn't heard of. I think it's the way NHS are moving. Tell me if I'm wrong, Daniel. Put your hand up physically if I'm wrong. But Internet First is ultimately going to be a replacement for HSCN. In the end goal, it's going to be what everybody's going to be moving on to NHS-wise. It's going to be their own internet, their own cloud-hosted solutions. When we go back to talking about regulation, we could see this move very fast. I mean, I've not seen any articles yet about this moving. I don't know if anybody else has. It might be interesting to hear about that. But I can see this space really lifting off in the next 6 months with all the cloud-hosted solution, with AWS, Amazon Web Services, hosting a lot of health data and really getting on board with the health data and showing the NHS that security is there to host data. It's not just Microsoft in the game now. You know, it's Amazon, it's Microsoft. You've got all of that now. So,
well, Amazon Web Services, I may be wrong, but about a year ago, I thought Amazon Web Services, in terms of the hosted service they provide, was approved by NHS Digital. So I think, and I may be wrong, possible I am, that it's more. A lot of it was around the application security as well when hosted on cloud software, on cloud-based servers. That may be some of the issue. I'm not sure Microsoft Azure has got the same tick in the box that Amazon Web Services have. I stand to be corrected.
Go on, Daniel.
Just a point, sorry to put in. Microsoft Azure is a certified NHS digital platform. They have a HSCN access, so you can actually tag into things straight from the HSCN, and Microsoft provide that. AWS doesn't. So you'd have to get your own connection. You'd have to pipe it off to your own. The installation complexity is higher. Yeah. And that's the reason why AWS has not been supported, because it may have some of the fundamentals on it, and people are providing it, secondary data centers are providing it, the hosting pattern on AWS and providing the connectivity, but AWS itself doesn't do it.
So the Amazon, sorry, Daniel, cutting there. Apologies. Amazon Web Service, from my experience, and this is a recent experience, is that the way when you procure Amazon Web Services, you procure a VPN into their setup, into the infrastructure that you've purchased, this bubble.
Yeah. And
that VPN can be obviously tied into your NHS Trust if we were NHS IT, and that thus gives you the HSCN connectivity. But you're right, Daniel, Azure has tapped directly in, hasn't it?
Yeah, Azure's tapped directly in, so you don't have to. What you have to do is you have to get a HSCN connection. You'd have to buy it, and then they would like BT would put that link into the AWS instance for you, right? And that's what you pay. Azure actually has a dedicated connection, pay data in, data out. Does that, so you can pass it in a secure way that way. That was the difference. I've looked at VMware, looked at very different cloud hosting providers, and as soon as I mentioned HSN connectivity, it's our job to make the connection happen between them and the hospital, rather than Azure, which has that connection already.
Okay, so I was on the right lines. I had the platforms the wrong way around, and but I was almost right in terms of the fact there's more about the selling party rather than the hosting platform itself.
But ultimately, they're both going the same way, and you can run AWS instances. You just have to. It's just you have to be responsible for getting the connectivity to it. And then of course you've got the cloud ISO standards and certification and security standards. You would probably want to pursue on top of that. But
All right. So, and I think this is where Internet First is coming along, isn't it? It's Microsoft driven, if I remember rightly, isn't it? Am I right in saying that, Daniel?
Well, they want to phase out the HSCN. So basically, the N3 was great for purpose at the time, but they've realised that there's a lot of services which aren't point-to-point one connections, and everything's going out of the internet anyway. So the plan was to try and use the HSCN and the MPLS network just to try to transition people onto having a secure connectivity piece. So eventually, it was going to be some time when they just remove basically the HSCN. So you have the same governance framework, but it all goes out over the internet. And that time of sort of removing the HSCN and going everything onto the internet is where they're talking like internet first. Yeah. So the idea, if they want to, they can run all services over the internet.
Makes sense. And then in terms of procuring apps and things like that, it's almost a modular model whereby you could deploy and innovate something very quickly into the Azure bubble, couldn't you? And then you just partition it to whichever site. And I think this really supports the scalability and shows where NHS Digital and NHSI, as those individual bubbles, are moving towards. Because I think the more sites that join up, I think it allows people to And the way I see it working, again, could be completely wrong, it's just my opinion, this one. The way I see it working is these big NHSI organizations, it's going to allow, once Internet First is out there, it's going to allow very individual organizations to procure each other. So the NHSI, they'll move to a different organization if they need to very quickly, and there won't be much of they won't be put off, as Craig put it, they won't be put off by fear, because it will be very much a modular exercise, especially from an internet perspective.
Absolutely, and they've standardized it. So if you want an app, it must have this security standard, this system, these requirements, so you can deploy it much easier rather than having to go down these segregated networks. Because what happened was the N3 and the HSN supported unsecure practices because it was considered a separate network. So people were doing things to secure it on the internet, like banks, because they didn't have that. But of course, because they had that, the people falling back on the fact it was supposedly secure networks. So they're pushing it into improve the standards of the services. As you're right, that makes it modular, that makes it easy to deploy, that means you can move it around a lot.
Yeah, quite right. Thanks, Daniel. So just the last 2 points are encryption and remote support methodologies that were brought up. But like I say, I don't want to go through all of this in detail. I think the important thing to note from this meeting is that this is an ever-evolving spreadsheet. This spreadsheet isn't going anywhere. I think this should be almost our working platform in terms of, you have an idea, don't write it in your book by your bedside table. Log on to your iPad whilst you're watching a film and stick it in there. I think it's ultimately, it's an ever-evolving list. You guys, I think it's open up to edit, so I think you guys can add to it. It's not something you need to email me about, but you're welcome to if you want to. But yeah, ultimately, we can keep adding to this and we'll move the work into the priority, and that'll be actively what we're working on day to day. Okay, let's see if I can get this back. There we go. So as part of one of the objectives I saw, it was harmonization of NHSI and digital alignment. I opened discussions with a chap called Roger Greer, who works at NHS Digital. Some of you may be aware of him. I think he's public affairs in NHS Digital. And I threw a load of questions at him, which were from the outputs of the last meeting. You know, some of the high priority questions that were raised up. And the initial questions were around the IT requirements of the R&D phase and the overall NHS digital alignment, as we know. And he come back with a whole heap of links, certainly around the standardization of cybersecurity standards and things like that. He threw around some links I'd not seen before. So I think what would be good is, I won't go through those in this meeting, but I'll filter them out. If I get a nod from you guys, I'll filter them out through Nat to yourselves to see if there are any benefit, certainly for the startups. I know we had that discussion in the last meeting. It might be handy to see what NHS Digital are coming back with. Is that something we're all interested in?
Yeah.
Yeah,
absolutely.
Perfect. Roger provided some central resource. We've covered that. That's fine. One of the big things that we had a chat with Roger about was the getting involved in policy. And I almost got a laugh, really, as to that seems a lot more difficult than just putting it into a sentence. And Roger, good for him. He went away and had a thought about how it could be done, and ultimately came back with an explanation around how policy is created within the NHS Digital and those NHS companies at the moment. And I think how they're working is it's almost a multifaceted event, as it were, when they create policy. It's not made by one organisation and brought in and proof checked or peer checked, etc. I think people dip in and out whilst they're creating policy. So I think it's a lot more difficult to probably get involved in those working groups, as they were, to try and help drive policy and benefit us as IVD organisations. So I think what we need to do first, and again, open to discussion on this one, I think we probably need to start aligning centrally as to what we want from the NHS, how we're driving the IVD market, what are our standards, what are our best practices. And I think we'll cover that in some of our priority objectives, when we define, I think, Daniel, you filtered something around shortly after the meeting, didn't you, about the, it had a lot of cyber security standardizations, that document, I'm trying to remember what it was called now. It was it procurement related?
Procurement related,
yes.
Security risk assessment, we now need to do in their procurement phase. If that's document talking about, yes.
Yeah.
I did say clear that, yeah.
So that document essentially details what good practice cyber security looks like and what we should be looking for within our software packages and things like that, and what we should be operating towards. So I think as an IVD membership, we should probably come together and agree on a document. And if we could try and maybe, my thoughts were we could maybe get it endorsed by NHS Digital, and then almost agreed with as a white paper. That could be one of the outputs that we define on it, and we all operate towards as a membership in terms of standards. But again, open for discussion on that one. Does anybody have any kind of good ideas around that side? Don't all go silent on me, guys. Especially you, Craig. Come on.
Not an area of expertise.
I think it's something we don't have at the moment. I think Europe definitely. I mean, Europe. That paper that we talked about, Daniel, wasn't it? It was from Europe that they're doing it, and obviously we need to understand where we stand. I know I think we've agreed to kind of endorse that methodology.
I think we're implementing legislation it's based on. To be fair, it's just their deliverable way of doing it. So the point is, do we want to get behind that approach and say, well, this is what's happening across Europe? And I completely agree. Get a white paper. Basically, we can see if we can adjust it and then get NHS Digital to agree it. I mean, there's ways around it. So then actually we're all following the same template approach. Yeah, so this is the UK. I think that's probably the best outcome for it. If that makes sense. I don't think we're going to get, because it's come from Europe, I don't think, unless something drastically happens with Mr. Boris Johnson in the next 6 months and we decide we're going to go somewhere else, I think we're still going to have some European alignment going forwards, of course.
I think that's where my head was on this, in terms of, well, it's a bit like every other regulation. I mean, if you go back in terms of ODU, well, post-Brexit or whatever, are our procurement process going to be drastically revamped to be something very different to ODU? Probably not. It'll evolution on. I went to a meeting, a couple of years ago now, down at the Cameron McKenna building in London, which was all about, in fact, probably 4 years ago now, was about changes to regulation post-Brexit at the time. So it was after 2016. And a lot of the noises, even then and still now, are about, we're unlikely to see drastic changes at that point where we switch over to being part of an EU organisation to being non-EU, that most things will be adopted. So this will probably be very similar, but it's useful to try and get behind something, I would have thought, and try and get some consensus before we get told what we're going to have to do.
Right, I completely agree. I think the advantage would be is if we could get it lined up so we get it standardised with NHS. So Brexit happens, yay, we have an NHS UK agreed standard we're following then. Yeah, so it means that then hopefully it means it won't change again, or it won't change again in the near future. It's just like rubber stamping it. Yeah,
I think it'd be great to have a paper that almost defines those standards, but it's also you see all these different requirements at different phases in different documents. So we talk about ISO, we've got a standard there. We talk about Cyber Essentials Plus, we've got a standard there. We talk about that paper related back to procurement, which is related back to IVD, we've got a standard there. I think it'd be nice to just have one document that says this is what we're operating towards as a framework. Yeah, that can literally almost, I'm going to use the word twice in one meeting, modular, which can also be modular in that it can dip in and out of the different policies and they apply to everything. And as long as we agree as an organisation, that's as an IVD market, that we're operating towards that, I think that's onto a winner for me. And it's all about just measuring. We'll say it later in the presentation, but measuring success is something I've been thinking about. We've got all these objectives, but how do we measure that they're actually successful? Is we do something, but do we know that we've actually overcome that objective?
I think time will tell with some of them, won't they? I think, but
yeah, for sure.
I mean, I don't think I think the problem with digital is because it's changing continually. There's no big win for all time, is there? It's just what we can do is build frameworks or give someone something to help them meet the challenges and review it again in a couple of years. But no, from my perspective, I think a white paper aligning the procurement standards, the sort of interfacing standards, all that type of stuff together, about what they want from software would be ideal. And the question is, if we want to do it from a product or a service perspective, and I'm really big on having it if needed, because if we design it one way for a product and you're offering a service, then you might end up in a grey area. So it's just finding visibility about that as well.
Yeah. No, I completely agree with that, because there's certainly going to be different requirements for both, aren't they? And we're already capturing that from Kevin with the software release and change. you've got all those requirements to take into account when it's a service a lot more. I mean, you've got that with, don't get me wrong, you've got that with product as well. But less frequency, there might be less of a requirements piece about it. We don't know, but I mean, you're quite right. Try and remove that grey area with one document if we can. That'd be great. Cool. All right. We're a bit behind time. Well, a bit ahead of time. Sorry, the other way. But I think what we'll do is we'll take a break. I was obviously feeling very Borisy when I wrote that, but yeah, I think what we'll do is take a break. Is everybody okay? It's 11:45 now. If we go and grab a drink and come back for 12. Is that all right?
Beautiful.
Awesome. All right. Thanks, guys. I am back if anybody wants to ask any questions or anything like that.
Nope.
Just general questions, Matt, or related to the meeting?
You related to Elvis? It could be related to me.
Are
No,
you a
I think-
Liverpool fan?
I am a Liverpool fan.
Are you?
Yeah.
So you were happy last Thursday?
Mm-hmm. Not so happy when they got beaten. Was it 3-0 by Man
I
City?
know, Man City. That was payback.
Yeah.
Wrong sport for me, as you all know. See on my cup. And my rucksack.
Honestly.
I'm like a school child, honestly.
Have you got your name on it somewhere?
No, ironed in the back of all my shirts.
Yeah.
You know, I've got a wonderful picture of my son from his first year at school. It's one of the best pictures ever. It's a picture of me picking him up from school when he was 4 years old, and he'd obviously just been starting to change himself after PE and stuff. He's got a pair of sunglasses on. He's got one of these these I forget the ties are called, with a kind of elastic on. He's got a shirt on but buttoned, but it's inside out but buttoned. It's incredible. He just looks like a right urchin, but it's brilliant. Like, how did you manage to button your shirt all the way up, but it be inside out? Mind blows.
You learned that your son had incredible patience.
But he hasn't. That's the thing.
On the other way around backwards is what he probably did.
There's an engineer brain that was, I didn't even think about.
Well, saying that or personal experience, one of the two.
No, you all get changed that way. I've just got to put on my shirt. Yeah. Means you can wear a shirt twice, guys. Twice.
Do you leave your ties done up on the peg as well, Daniel? Like you used to do at school, and you have a thin side one day and a fat side the next.
What? By the door? I hang them up at the door on the way out, make it really streamlined. Yeah, don't have
So the next section is a little bit experimentary. Has anybody used the breakout rooms in Zoom before?
No, I haven't.
No.
Should be fun. Should be fun.
It's less exciting than it sounds. It sounds like a virtual escape room, but it really isn't.
Yeah. It does mean you have to come back still.
It might turn into an escape room, depending on the subject.
Absolutely.
Okay. It's hard with webinars, isn't it? You don't know when people are back. You don't know if they're still there.
I have the same issue with live meetings, Matt, if I'm honest. Never sure whether anyone's fully engaged, but then that's just the way I present.
So even if they're sat in the room.
There you are. And there's someone who experiences it regularly.
That's it. We'll give it till 12 on the button.
I'm back and all set to go.
Hello.
Hi. Postman's just bought me a thank you card. It's really nice.
What's it thanking you for?
Somebody
Is it from the postman, or has he just delivered it on behalf of somebody else?
he's delivered it on behalf of somebody
Ah,
else.
Oh, okay. So, it very much sounded like it was from the postman.
Yeah. No, it's very nice of him. Somebody sent me a little thank you for some stuff.
That's nice.
And he posts a biscuit through for the dog as well, so she's happy.
Really? How postmen keep their dogs happy and all that, rather than being chased down the street as they stereotypically are. Okie doke.
I was fine with the postman until the postman's carrying a parcel, then he just goes ape.
It's what they're carrying in that parcel. It's
Is it edible?
ex-drug doggers or something like that, you know. Okay, so we'll crack on. So the next sting I thought we'd do as part of this, and like I said, it's a two-way meeting rather than just me talking in my dulcet tones for a few hours. We're going to try and split up into 3 groups. Okay. What I'm going to do, I've defined the groups within Zoom, and you're going to go out into some breakout rooms. Okay, so your Zoom is going to reload and then basically put you into another group. And what I'm going to do, I'm going to tell you who you're with, and then we can say which groups. Where are you? When it works.
Am I going to get picked last, Matt, like it was at school football?
Possibly. Let's stop. Stop share. Let me stop the screen share for a second. And I'll go to breakout rooms. Right. So, group one. Each group's going to have their own questions to ask. Okay. And the idea is, if you guys nominate a spokesperson within your group, so we can feed it back when we come back, and we'll go through each one again to drive some outputs. But each one's going to have its own questions to try and the idea is that we get, like we agree with the white paper earlier on, really, it's to actually get some outputs from these objectives, because we could talk objectives until, until we go blue in the face. But ultimately, I think we need to come out with some objectives or some outputs from these objectives. So each group's going to ask some questions. I'll let you guys know first which groups you're in. And if your name's not mentioned, you're going to be in group 3. I think is the easiest way to say. So group 1 is Daniel. There's not 2 Daniels in this chat, is there? That's good. Yeah, there's just 1 Daniel. That's fine. Doris Ann, Kevin, Ollie, and Richard. Okay, so if you want to take so the question for you guys is, how can we achieve digital alignment within our own IVD market? So let me know if you want me to say that again. Awesome. Okay. Group 2 is Craig, Helen, Nigel, Tim, and Timmy. Okay. And the group 2's question is, how can we help improve clarity surrounding Windows 7 to Windows 10 upgrade life cycles and processes? So that clarity could be around contract clarity, could be around upgrade processes. Let me know if that question is, if you want different people to tap into that. I'm happy with that, but we can have discussions about all the feedback if nothing comes of it. All right. And then if I've not mentioned your name, you're in group 3, and you won't move when I click the button. But group 3 is, how do we improve contractual accuracy when it comes to Windows operating system upgrades maintenance? Okay. So I'm going to do open all rooms. Hopefully that means you come back. Go on, sorry.
Can you please repeat the question for group 3, because it was a really long one and I don't write that fast.
No, that's fine. Group 3, you're staying here anyway. You're with me.
Okay.
So I will say it again in just a second. You're fine. Okay. So I'm going to click open all rooms. What's going to happen? You're going to have a countdown. It's going to be 15 minutes. I put 15 minutes. Should it seem reasonable? Give me a nod. 15 minutes, too long, too little? Yeah. Yeah, cool. All right, we'll do 15 minutes then. And then it'll do a timer. But I think after the 15 minutes hits, it'll basically do a timer of 30 seconds. It'll bring you back. Okay, and you'll just click on your screen to bring you back. I'll send any messages if we're struggling for innovation, as it were, and ideas. I'll send messages out and say help. But yeah, SOS, yeah. But I've tried to make sure. I think Craig, we've got a co-host in each room, I think. So I think you might be able to send messages possibly. But yeah, pop us a message to us if the group's finished, etc., and we can maybe cut it short or however we want to do it. But it's a bit of an experiment. We'll give it a go. Okay,
experimental kind of day, isn't it?
Yeah. So I'll see you guys in 15 minutes. If I click open all rooms, I think you've all been invited. You should have popped up.
It's a bit like being zoomed up and down with Star Trek.
It is. I think we're okay. Awesome. Perfect. So we've got Yasmin, we've got Nadia, and we have LD Pro. I don't know who LD Pro is. I know iPad not joined. So Nadia, how you doing? You okay?
I'm good. Yes, thank you for asking.
Good. So our question, because you asked for it again, our question is, how do we improve contractual accuracy when it comes to Windows operating system and upgrades and maintenance? So we're trying to think of some outputs, really. It was something that came out of the first meeting, but we're trying to understand what actually will drive improvement and what outputs will drive improvement ultimately. Is it a white paper? Is it a process change amongst our market? Is it something we need to get speakers in to kind of help bridge that communication gap between us and the health service or our customers? This one's a bit out of my depth in terms of the question, so I should have put myself in one of the other groups, but obviously I like self-harming. But yeah, in terms of contractor accuracy, I think it was thrown up last meeting around, there's a bit of ambiguity around whose responsibility it is when it comes to upgrades, system upgrades, maintenance of the operating system, and upgrades and maintenance of potentially the software that you guys provide or the hardware that you guys provide. Do you guys find that yourselves? Do you not find that?
No, but we're offering a cloud solution, so that's depending on what, not really depending on Windows as a system.
So you provide a service, a solution, as it were. Yeah. So that solution, I imagine, must undergo changes or must undergo upgrades and things like that, I guess. So I presume as a solution, it's more black and white then, is it, around changes? So you just implement it and they just have to accept the change?
Yep.
Is there do you not suffer with kind of any having to go through the change cycles with your customers? So making sure they're tested and things.
It depends a bit on what we're updating. So we have actually separated the system into the platform and the bit that's actually important for, so it's a data interpretation software. Yeah. So the bit that does the interpretation, we're not the legal owners, and we've done that on purpose because that's the bit that's actually doing everything as a medical device. So that needs to be validated and everything. But the platform itself, the bit that we are the legal manufacturer of, if we do any updates on that, it shouldn't have any impact on how the analysis is done and interpreted.
Okay. I see a face there, but unfortunately, I don't know your name. I'm sorry. Your name's not popped there.
Matt, Nadia, you remember me? It's Ian from Launch.
Ian, how you doing? You okay?
Hi, you look like you've been on holiday.
No, not really. I think it's this backdrop. I've been riding the bike probably, but for a few days. But no, sorry, Matt. I wasn't being rude. I was just listening really, because this is the first time I've jumped into the digital working party.
That's fine. Welcome.
And I don't want to, for us, because we're a distributor, we don't manufacture. Some of it obviously is, I wouldn't say not applicable, but I'm just listening first of all, just to sort of like get up to speed. So apologies, I'm not being rude. I'm just writing and listening just to hear what's going on, really, just to try to get up to speed.
No, it's absolutely fine. So I think this one came as one of our low-hanging fruit. I think the idea was to split off into groups and kind of decide on the outputs to try and identify and fix these issues that were clearly issues amongst the group in the first meeting. Try and get these low-hanging fruit sorted out. The contractual accuracy, I mean, for us, speaking of Sysmex now, not Sysmex hat, not BIVDA hat on. For us, we have a lot of ambiguity between our different levels of contract. So we have our managed service contracts, and then we have our core contracts, where we're a secondary bidder, or and we fall part of that. There's a lot of ambiguity when we deliver, whether that be a service like yourself, Nadia, where you deliver a solution, because we deliver that sort of thing as well. But we also deliver the hardware and the package that comes with it. And there's a lot of ambiguity when it comes down to whose responsibility is it to maintain that hardware once it's delivered. Is because ultimately, if you were buying a system as a consumer, if you were going to PC World, Currys, or just a PC shop, and you just go and buy your PC, it's now your responsibility to maintain that, unless you pay for a service contract with that firm who maintains and services that instrument or a PC every year. And I think there's a lot of ambiguity when services or systems and solutions are delivered, whereby it's not defined. It's not. It's never defined whose responsibility it is, and therefore whose cost it is to ultimately resolve that.
I think as a distributor, Matt, for us, our general rule of thumb is if we've provided the IT hardware to run the instrument that has its own operating system or own application software, then we're responsible for the upgrade. Now, if it's most of our equipment are standalone, and they're not, mainstream, they might be, we're added in as a third-party contractor for esoteric tests, etc. We're not after the big biochemistry or hematology line type of product. So ours is really quite small, and predominantly the issues that we have are only really related to instruments that are within a network, a trusted network, whether they are, dumping files to a known server or location, or those that are interfaced. Now, okay, they can't get access to the internet on the PC when they're interfaced, because that's just, the PCs aren't set up for that. So we're only talking a small window of people like the blood banks or other locations whereby we have remote support access, and it's on their network. And predominantly our focus is, if the instrument fails and there's a new operating system that's available that goes hand in hand with the software that runs the instrument that's been validated on Windows 10, we put in a Windows 10 platform. We wouldn't mess about and go, oh, no, sorry, we're just going to keep it Windows 7. We want to make sure that we move people to the right operating system, that then if they then decide to put it on their network or whatever they want to do, we don't have an issue with hospital IT saying, oh, we can't use this product because it hasn't got the right operating system, or, Windows end of life, etc. So for us, we've got some analyzers, about 130 in the UK, that we're going to have to go through this process, because Windows 7 end of life is finished, and the manufacturer has released new validated software for the instrument that runs in a Windows 10 environment. And obviously there are some software anomalies that have been resolved in the new version. So we're sort of like forced to move to a Windows 10 environment, really. And it's a slow and gradual process. So we're prioritizing who we have to do first, and then how do we go about all the other customers to get those upgraded.
So I'm curious then, is that defined? Because obviously you've got the life cycle of Windows 7 to Windows 10. So Windows 10, that happened January 2020 if it was on Windows 7 Pro. Did you just at that point generate a report and go, how many Windows 7 machines do we have out there? It's now at our cost to replace them? Or is it as part of the contract, or is it fed as part of the contract that it's the customer's responsibility if it falls midway between?
Yeah, it's a good question. In the contracts, where the responsibility lies with us for the equipment that we place, because most of these are agent rentals, they're not capital purchase. So ultimately, we own the equipment. And so from our point of view, it's our responsibility. And IT and the trust don't want to touch it, because they're like, well, we didn't install it, and to be fair, that's absolutely fine. We're not on their network, we're not using their antivirus. Most of these are standalone instruments running a standalone application. They don't need internet access. They don't need Office 365. It's just a box to run the equipment. And so predominantly, we've got to take the cost. Now, some of the hardware we can put in, we can upgrade to Windows 10 from Windows 7. So it's not complete new hardware. It's more of a software refresh. But some are old that we're like, listen, let's replace the box, Windows 10, update, and it may mean we have to update the interface software that links to the host as well, because that's based on a Windows 10 validation. So we are sort of like going through a slow process of working through and making replacements at our cost. But what you raise is really important from a contractual point of view, because we work with Roche, Siemens, Abbott, Sysmex, etc. So from a contract point of view, predominantly most of the hardware responsibility is ours. And we accept that.
So what do you do then? So I think the reason this was brought up last time, I think, is because a lot of companies have fallen foul of Windows 7 has such a breadth of life cycle. It's 10 years, obviously. Most Microsoft operating systems are. I think a lot of companies are falling into the trap now where they've had such good business over that Windows 7 period. So they've got loads of equipment out there, loads. And then at the day dot that Microsoft says, sorry, Windows 7 is not supported, January 2020, all IT departments went, you've got to replace them. You know, even if it's not connected, you've got to replace it. And like you said, you're doing it as part of your cost, and there has to be a phased approach from your perspective.
Yes.
To even you know, just managing cost flow financially,
Yeah.
but also from a perspective of, again, you don't want to be left in the position in 10 years' time again when you're replacing 400 machines again at the same time because you rush to get those installed and replaced. So, I mean, I think the big issue around here is trying to come up with a process across our market where we have a piece of wording, I think, that says we will stagger. We will stagger installations based on, or we are exempt from this upgrade process because. And I mean, I don't know what the answer is.
I think a
really.
white paper or guidance is important, because if you don't have some common guidance, then that you can distribute, and whether that's endorsed by BIVDA, you know, I think that would be key, because then we can provide the same message to everyone and say, listen, you know, we understand that you want to move to Windows 10 environment, but from our application, it's not needed. We can run it standalone. You know, you're not using it for the internet. You're not using it on your network. It's not on the domain, wherever. You know, so from an instrument performance point of view, it's not affected.
The problem you've got is ultimately. Have you done the Cyber Essentials Plus certification within your organization?
Yeah. Well, we did NHS Digital. We've been really in close contact with NHS Digital, because we looked at some of their documentation we said some of the questions were for large corporations, and not small to medium. They said, "Oh no, we won't be changing some of the questions for small to medium enterprises for quite a while." And we were like, "What does that mean then?" So we can't fill it in. So it's been a bit ambiguous. I've got a quality and regulatory manager who is constantly banging his head against the wall, going, you know, this is just impossible, because we had a referral service that we have as well, and obviously there's quite a lot of patient data information resolved in that, with shipping patient samples from here to a lab in France and being tested and coming back. So there's lots of complications with that. But just going back to your original question, I think having some guidance from BIVDA about, you know, what needs to happen, because I think also some IT companies don't understand that some of the manufacturers haven't validated new software versions to move on to Windows 10 yet. They're in the process of doing that. Until they do that, we can't move forward and say, oh, we'll give you Windows 10, even if you want it or you're pushing for it, because the current version isn't validated in combination with the operating system. So you're sort of like juggling multiple balls, and when you're a distributor, you're at the hands of the manufacturer. It's sort of like, you know, we've been pushing for months for some suppliers Windows 10, and they're still like, you know, we're in the process, you know, we're focusing on, you know, IVDR and GUDID, and it's just like, well, okay, but you know, for us, it's just very difficult.
No, I don't blame you. I mean, going back to the Cyber Essentials Plus, I think the obviously you said about it's not related to the smaller company doesn't help it. I completely agree with that statement. I think there's still much to be evolved with that.
Yeah.
The problem NHS organizer, if we flip side that, and I mean, the majority of our customers obviously are they're healthcare providers at the end of the day, and they're trying to do Cyber Essentials. I know that it's a big push in the NHS at the moment, if that's your core market, around Cyber Essentials Plus. And I know from experience, and you'll know if you've seen the questions, they have to basically answer a question that explicitly says,
yes,
you have what in your estate, what operating systems you have in your estate. And if you mention Windows 7 or an unsupported operating system or software, just making it more relevant for Nadia, so it falls in that, you know, it will be an instant failure.
Yeah.
And so, I know you don't have it, but from an NHS perspective, the IT department has to push the Windows 10 button and supported software button, because if they write in that box, we are in scope and we have 15 Windows 7 PCs, they don't care who they're provided by. All they know is that they're on the network within that NHS network. So therefore they get an instant failure.
I know.
And if you get an instant failure on Cyber Essentials Plus, it's some big kickbacks on the trust level.
I think, Matt, there's got to understand there's a transition, because I can't believe that every NHS trust, with all the computers that they have, and some of them have XP in some of these.
I know.
You know, they are not, you know, they're pushing us. It's a bit like GS1. They're pushing us, and yet what are they doing themselves? So for me, I think it's not a process that we're not going to do. It's a process that takes some time, and you have to prioritize what are the key accounts first. So, you know, those ones that are networked on a domain, those ones that are, you know, potentially on an interface, if somebody argued, you know, you could say, well, actually, it's not a necessity, but you are linking somewhat to the information system of the lab, so we would update it.
So I think off the back of what you're saying then, so what I've noted down here, tell me if you agree or disagree, guys. I've got down here, I think there needs to be a guidance paper regarding life cycles and how this relates to CE marking. So product life cycles, software life cycles. I think we need to come to get a piece of document that's created between us that defines what that is. And then we need to, as part of this, and this could be the same document to be honest, I've got here, define what's in scope and out of scope. So you say interface machines, we say software, you know, as a service that we're just providing. Are they in that scope or are they out of that scope? And I think we need a clear definition that lists that to say this guidance is for this and this guidance is for this. And then we operate that. We operate within that as an IVD market. Sorry.
I think it's a good idea. I mean, for Nadia, they produce software for customers. That they're a software development house, so it's different. But you know, I think for selling or for giving guidance into the NHS, it's always rather fragmented. And I think everyone can produce something from their own letterheaded company paper, but I think it gives it more cohesiveness, more of a cohesive impact if it comes from BIVDA. You know, we can present this, you know, if some ITs are saying, well, it's absolutely essential, we can say, okay, well, here's the BIVDA paper, you know, we're working towards that, and you know, and there you go. Because as you've probably experienced, Matt, some people are like really intense, and some people are like, don't worry, you know, we know you're working on it. You can come,
it's one spectrum to the other.
To us. Yeah. So I think having guidance, I think, is critical in an environment whereby, you know, it can get considerably confusing with the amount of, you know, documentation and information. If it just comes from a centralized location and it has the authority and represents the views of all the people, I think that's quite a fair statement. And I think perhaps IT departments would accept it and say, yeah, okay, you know, we understand you're working through it. It won't be instantaneous, as I'm sure, you know, replacing all their Windows 7 PCs in their environment isn't an instantaneous process. But, you know, after the WannaCry virus, I'm sure they are, you know, it's a big focus. So yeah.
I mean, that drove change very quickly and drove compliance massively within the industry. What's the, Nadia, we talk about the rapid software release side. Do you struggle against what Kevin's pain points are as well?
No, because I remember talking to him about it last meeting, and I think the difference there is that we have this clear separation between the platform, which basically doesn't do anything, and the bit that's owned by the assay developer. And the platform we are constantly updating based on customer feedback, and as mentioned, it doesn't have any impact on how the little bit that does the analysis works. So it's quite low classified also with CE mark and everything. So we don't see these different or this struggle with these updates.
So it sounds like it's related directly to the data that you're managing and processing. Then the risk is that small. But again, it's kind of the spectrum of people don't care. People almost don't mind that you're just updating. It's better for them as product development.
Exactly. It's often just, you know, adding an extra functionality or a button that is going from the left to the right. It's not major things impacting how the system works. That is something that we do validate, and we only do that when the legal manufacturer of that bit of the software tells us to.
Okay.
So that's not that often.
So the frequency of such large changes just doesn't happen with yourselves. Exactly. It's not, you're only changing functional changes or operational changes, not core code structure, as it were, or core software structure. That happens kind of once a year or whatever it would be time-wise. And when you come up to those changes, do you have pain points, or is the procedure that rigorous that actually it doesn't matter?
Do you mean the
big changes? Yeah, the big ones once a year that you're changing on the whole platform.
So the only problem that we sometimes see is that people don't have the admin rights, and somebody from IT has to come in and give them admin rights or open the admin rights to update the software, because if we push through these updates, they can't go on until the update is done. And the functional changes, they need to be validated. So they will only be pushed when we have this whole validation process and everything done.
And do you show the customer that, like we have to, like a lot of time in the IVD, you have to produce the reports that show the validation process. It takes a lot of resourcing.
Yeah, and the technical notes that Kevin mentioned, indeed, then we have to produce those. Yeah.
Okay, so I guess the frequency is just a lot less than what Kevin's mentioning then. So you don't experience what Kevin's saying.
So I think for him it's different because it's NGS, and that field is just moving a lot more quickly. We're in molecular diagnostics. So it's only when, for example, it's an influenza strain that's changed, so we need to take that into consideration with the analysis. That's maybe
there's been one recently, Nadia. Just let you know.
I know. Yeah.
So I'm guessing you've been busy recently then.
Extremely busy. Yes.
Okay, awesome. I think when we've got some outputs on this one, then I think it's a case of we need to just get some ownership from it. I.e., I need help. we need. I think we need some of the guys to kind of, again, especially when it's not your field, it's difficult to write a paper, and I think we've got enough people to peer review enough to kind of add some inputs on these different points. I'm trying to see on this experimental breakout rooms if you can see how much time's left. No, can't see it. Well, we'll give it until 12:30. If you guys want to grab a drink or anything like that, you're welcome to. Is there any points that you guys see as your own individual working areas that's not being covered as part of this that needs to be, you think? It's quite a broad question. I appreciate this. The digital side of things is, the thing is, for digital stuff, I always say it's a backup, isn't it? It's never seen as a priority in all of this. It's never seen as at the forefront of the conversation topic. So I appreciate it's a difficult question. But.
It's a good question, Matt. I don't know at the minute. I can't answer that yet. I'm sure as we go through some of these, it's looking a bit, the path's looking a lot clearer in terms of, what's applicable to us and what isn't. I mean, we have a general good overview of what's happening. But I think because we're only a distributor and a small to medium enterprise, we just get on and do things, and the bigger manufacturers, the bigger providers, the enormity of scale for them is significant, whereas to us it can be quite a small task.
What do you distribute?
We distribute automation and diagnostic tests throughout the NHS. So we've been full on since COVID because we supply molecular tests to the NHS, extraction systems, amplification systems, all sorts. So since March, we didn't furlough anybody. We've had staff working from home, but from an operational point of view, key directors have been in. So we've had warehouse workshops. We have engineers. So it's been full on for us from a company point of view. Although routine testing has reduced, normal routine testing in terms of our markets like micro, hematology, those products have reduced by 50% because they're just not doing the testing. People aren't coming through for lab-based tests. Well, COVID obviously has just gone enormous. We are starting to see signs of some resumption of normal laboratory tests, whether that's in bacteriology or whatever. So at some point there'll be an equilibrium whereby we're pretty much level between COVID and normal lab tests. But how that will fare in September, October when the flu season's back and we want COVID and respiratory testing, I just don't know.
I think we're going to be left picking up the pieces, aren't we? Let's face it. I think with that, it's going to go manic. That's a hunch on my part, but I think with anything, like we said, with the digital working pie, there's changes being made that we're going to be unfortunately picking the pieces up with all the changes. But
I don't think we'll have any more furlough. I think it's going to be, you just have to get on with it.
Yeah,
you've got the infrastructure now. They've put the investment in, and it is, the economy comes first, and you've just got to get on. And we've got the capacity to deal with people who are ill, and yes, there might be pockets or enclaves that are locked down, like we've seen in Leicester and other places. I think that'll be the norm until a vaccine is available, I'm afraid to say.
I completely agree.
You know what I mean? It's just the economy is the priority, and there's a significant amount of people that have suffered, hasn't there, as a result? So,
sadly, so.
Let's see what Boris can do to build. Apparently. So we'll see. We'll see.
Broadcast a message.
How are you, Nadia? You well?
I'm good, thank you. How are you?
Yeah, I'm fine, thank you very much. Yeah, really well. How did you cope in lockdown? What was happening in Belgium? I know things in Sweden, people weren't social distancing, and I know they're suffering a little bit. But what was happening in Belgium?
I don't know actually, because I live in the Netherlands, and they shut us out quite quickly because they said our government wasn't responding fast enough, so we weren't allowed in. Okay. But they were allowed in the Netherlands, so there were a lot of. I live quite close to the border, so on the weekends, because the shops and restaurants were still open here for the first 2 weekends, I think. There were a lot of Belgian people here taking advantage of the fact that we weren't in lockdown yet.
We weren't in lockdown.
Yeah.
Yeah.
Well, Mr. Jones, how are you?
Yes, I'm not so bad, Craig. How are you?
All right, you just popped up on the screen then in like full HD.
I did, yeah. Sorry about that. I
no apology needed.
I wasn't being rude, Craig. I was just listening more than anything, because this is the first time I've joined, so I just wanted to gather, get a grip of what's going on before I show my ugly mug on screen. And
when you figure it out, let us know.
Yeah, I will do.
Okay, guys, how are we getting on with everybody? Did everyone come back successfully? This is the interesting one. Did the groups work okay?
Yeah, I left early. Yeah. You saw my list of groups. I wanted to get out.
Perfect. Okay, so did Group 1 nominate a spokesperson? That was the question.
Which one's Group 1?
I can't remember. I've closed the groups now. Someone's got to be honest.
Yeah.
Someone's got.
Daniel's going to feedback from us.
Awesome. Go for it, Daniel.
Right. Well, we had quite a big discussion. It was very interesting. It was about how to align or how to achieve digital alignment in the IVD market. And I think we spent a lot of time really struggling with the concept of what the IVD market means. And I think realistically, the feedback we gave is there is no real opportunity to do it for all IVD, right? Because unfortunately, the use cases, the customer, the delivery of digital within these different spectrums, whether it's going out to individual customers, going straight to the public, whether it's going to healthcare institutions, whether it's going to research institutions, all these will have different drivers, different ways of working, let alone when we're talking about genomics, they have their own specific use case for specific standards against them. So it's an incredibly complex field. So I was probably suggesting that there's probably 4 areas we can look at, but we probably need to really narrow it down into specific regions. And one was sort of like the hosting of digital systems, the sort of how we provide digital systems, whether it's in a cloud, whether it's in physical, get some agreement and alignment on that, or how we want to approach that, like, if get preferred suppliers for cloud hosting, things like that. But that's just like an option. Connectivity is a huge one, right? API, standardized interfaces, standardized sort of technologies, try and move away from legacy. Risks with that and underprongs of that is a lot of the stuff's being gatekeeped by other people, list providers, people like that, which we don't have any control over, but that's something to discuss. Yeah, contractual and regulatory requirements. We think that's pretty much aligned, really. We're looking at the IG toolkit and the ISO toolkit. I actually think that's pretty good if you meet that, because there's lots of different ways to deliver that. You can choose to get ISO certification. You could choose cybersecurity is essential. But basically, that's realistically, from our perspective, that alignment's there because that brings in the different data regulations and security regulations. So that was the outcome we had from that. But realistically, the suggestion was we'd probably want to define which digital market we were looking at further, and probably look at actually having different approaches, different digital markets.
So which buckets? You're basically saying which buckets do you need to fill, basically?
Yeah, well, exactly, because from Sysmet's perspective, we'll always be looking into the hospital sector, we'll always be looking to the NHS delivery of healthcare, or pathology testing sectors. That's different from a research sector, yeah, who will have to work with universities. Yeah, and that's also different to people that are making apps that go out to the public. Yeah, so
yeah,
we probably, from the feedback I'll have, it's worth looking at that, looking at 3 core areas. I think that's where we need to look at it. The hosting, the sort of like connectivity, and the regulation around it. But ultimately, I think we need to define a bit more from a group perspective. Maybe even get a bit more direction of which one we want to prioritise. Yeah, where we think the biggest risks are. Because of course, I'll want to bring up, talking to NHS systems, looking at healthcare, looking at pathology, because that's driving me. Yeah. So,
I think then, do you agree then, is it fair to say that we need to define the different elements of IVD first, and then go from there?
I would look at it from a provision case, and then you can look at the sort of interested parties with each one. Yeah, because I think the interested parties pick up the requirements. Once you then know the requirements, you can put what they're working to, and then you can start looking at alignment. Yeah?
Yeah.
Yeah. So I think from that sort of the feedback we sort of have. But I said the one thing we were, because we did have different people, different regions, the contractual and NHS toolkit is the agreed standard, and it does work. Yeah.
Okay. What I'll do from the back of this then, if you think it's worthwhile, should we create? I'll create. You guys have obviously all got the link I've sent out today for that spreadsheet. We'll create another worksheet on there just so we can capture what people think of the different areas. We may well end up with more than 4, but we then can at least harmonise them and go, okay, there's an agreement that one falls into this one falls into that one. So we define it?
Yeah, so 3 areas within the of the IVD market, which is the hosting, connectivity, contractual requirements, and sort of monitoring. And then how we want to break down the market was the bit I think we probably need. Because I think those 3 core areas are consistent across the board. Yeah?
Yeah.
But I think it's which part of the markets we try and align with. Because there's little point, us trying to force alignment on a research spec, which is dictated by genomics. There's a little point genomic specs dictating to hospital trusts. Yeah.
Yeah.
So it's trying to get value out the end. I mean, this is the ultimate job of this, is try and get some value which assists us. So I think, unfortunately, in this case, IVD is just too broad.
Okay, that makes sense. So what we can do between now and the next meeting is possibly come up with those, and then start honing in on that to come up with some objectives. I think that's a good idea. So awesome. Thank you, everyone at Group 1. Appreciate it. Group 2, who was the nominated spokesperson?
Is that us?
I think that's you, Craig. Yeah.
So I think it fell to me because I was actually making notes. And they said, "Well, as you've been writing, you can lead." I think there's probably going to be a theme. Clarity was the order of the day. So in terms of background, we were looking at the usual scenario of migration from Windows 7 to Windows 10, but also Tim mentioned something important. It's not always Windows 7 to 10. It's just to 10, because there are scenarios where solutions just are on Vista or XP just because they always were. Helen mentioned about microscopes and MS-DOS, just are. And
they're forcing those to Windows 10, are they? Is that what you're saying?
Well, so here's the thing. So the issue, what's needed is, well, in terms of the background, you've got a situation where you've got solutions which are not networked, are never going to be networked, have an internal operated system. So you could end up with the nightmare scenario where you've got a trust policy which insists on your solution being upgraded to Windows 10 because a policy says so. You could be inside of a managed service contract or a direct contract with the trust, where the terms of the contract dictate that you are liable for all patches and updates as required by law or in accordance with trust policy. You could also be in a situation then where you've got a solution which can't be upgraded and doesn't need to be upgraded, but you could be in a horrible situation where you as a potentially subcontractor with liability of risk could be in a position where you've got to find an alternative to avoid a fine. So what's needed really is a situation where you need, the clarity is needed from an NHS body, be it NHS Digital, Department of Health or whatever, which can effectively be inserted to provide clarity to those contractual points, those policy points, or those legal points, which says, it goes back to what Daniel was saying about definitions and clarity, definitions of an almost a grading system of which system types are priorities and must-haves. Almost like a tender spec. You get your must-haves, your should-haves, and your would-like-to-haves. And the would-like-to-haves could be things like the microscopes. Yes, we'd love them to Windows 10, but they're not. And they're not going to be for a while because the manufacturers or any of the products are not upgrading them yet because they don't need to. And they may well be for, manufacturer X. They've got some systems which are fully integrated, digital image scanners, and they send stuff off to the hospital information system or onto an EMR or to a cloud storage system. But others just sit on the bench. They've just got an electronic operating system. So they would sit somewhere else in the hierarchy. So some form of clarity, and it kind of goes back to something we talked about, Matt, when we first started thinking about this group, is it touches almost there on the procurement working party group activities and regulatory affairs. So that was the overriding thing, really, clarity on what's meant, and that needs to be, and to quote somebody else in the group, it wasn't me that said this, a piece of paper you could wave in front of an IT jobs worth of the trust and say, well, I'm sorry, we're not doing this because, and here is the NHS guidance and policy.
I think in order to get that, and correct me if I'm wrong, you would need an element of endorsement, that's for sure, to have a paper with such weight behind it. I think the crux of the issue that you come up against with, and I'm going to put my IT hat on again. Imagine I'm Trust IT, nobody's going to like me, but ultimately it's the Cyber Essentials Plus certification, which black and white says in scope, if you have out of support software, out of support hardware, out of software, operating systems, anything that falls outside of that, then you are in breach of Cyber Essentials Plus, and therefore it's an instant failure. So I think I can see from an NHS's perspective pushback on that to try and define what is in scope and what's out of scope. And we come up with a similar thing in our kind of group 3 questions, really, almost defining what's in scope and what's out of scope of that, to hold in front of an NHS trust and say, why is it out of scope, to help them understand why is it out of scope of your certification. And
relevance, of course. Because an awful lot of the time, and we've seen this throughout the years, whether it be contractual obligations or KPIs within a topic of conversation, that one size does not fit all. And they say, well, here's an IT policy, Windows 7 is coming to an end, everything's got to be on 10. Well, hang on a minute. Have you really thought this through about how many touch points this has within the healthcare economy? And I think there's a disconnect in terms of, you mentioned it on the previous one, defining the different strands of IVD is quite crucial in terms of what needs to apply and how it should apply and where it should apply, and the relevance of certain policies and requirements being applicable to those parties within it. Sound like a lawyer then, but you know what I mean. That makes sense.
Can I just say something? That's all right.
Absolutely.
Sorry to butt in.
No, not at all.
What they're coming from is a risk perspective, and what Matt was getting at was the risk perspective. When you put an iPad, it's all about risk, right? It's all about where problems and where threats could come from, right? So rather than trying to get the customer to white flag something that they're, or say if something's okay that they're clearly not happy with, why don't we try and have a standardized risk grading for these platforms based on the
exactly right? Yep, that's right.
Right, and then rather than trying to go in with this is DOS, certify it, because they're going to tell you to get lost. Say the reason why this is category low is because it's a microscope, it's not a network, it doesn't have a USB.
Yep.
Yeah, it doesn't actually do anything other than sit there and run this little bit of software. It doesn't do anything. For example, you get that, right? And you design the risk categories, so then they go, well, actually, it is low risk. Fine, tick. So you take the thinking off them, because the problem you try and engage. As soon as you engage with what they think is acceptable, you're going down their policies and their process, right? But this way, and it's not, you're not trying to jump them. You say, well, I've done the risk assessment for you. Yeah.
Oh, absolutely right, and that's exactly right. And I don't know all of the manufacturers, goods and services across the IVD sector. So as somebody who's been involved in it for 20 plus years, I'm pretty sure someone involved in Trust IT doesn't know even a fraction of what someone like me would know. So how would they be able to risk profile something yourself? So exactly right, Daniel. Having a predetermined risk profile by type would be ideal.
I think this should be something that sits within IVD as a software. With the CE marking, really, there should be an element of this product for. They do it with the medical devices, don't they? That falls in with a particular grading depending on what diagnostic analyzer it is and what risk it poses. Really, we don't do that with the computer systems that are attached to it. So it's almost like we need to have an element of where does it fall into? Is it connected? Is it behind a firewall? What's it going to look like? All these different.
That's a good example, because I used to work in a distant life with a Dutch firm that had a data management system and didn't touch any patients. Aggregated data from vendor pacemaker programmers, effectively, and it was a constant running battle with Trust IT to categorize it, and they refused to accept that the category it was in was nothing to do with patient contact. It's not producing any data. It's just aggregating it. So it was a very low risk, but they refused that because it sat in cardiology. And sometimes that's the problem. It's the perception of where it is creates issues. So in terms of lab diagnostics, it's in lab diagnostics. They therefore perceive it's a high risk, irrespective of what you try to say.
Absolutely, but I think you have to look at what data you're handling. It fundamentally comes into this risk assessment. Yeah, if you're getting a point of identification for customer and you're generating medical data, whether you like it or not, you're in GDPR land. Yeah.
Oh yes, absolutely.
No matter what you're flying and what thing you're doing, it's not you're not going to be able to square that round.
Your score is instantly up here, isn't it? Basically, as soon as you hit that.
Yeah.
Yep.
So what I'm trying to get at is, and so if you're saying, yeah, we provide bi-directional six patient factor results matching, or whatever the hell you want to call it, by 6 features. Sorry, you can't get away with DOS. But if you're not, and you're not doing anything like that, and it's just sat on the platform, then you don't need to worry about it. So I think that when they say this risk assessment, that comes into it, and you a transparency of it. This is our risk criteria. This is our risk of these 6 things. And we agree it as a BIVD organisation, these risk categories and risk outcomes, and then literally that's what we push back.
Sounds good to me.
I think what we do then off the back of this, and again, correct me if I'm wrong, I'm just trying to direct it a little bit in that if we define the different IVD areas from the first option, we define that first. And then off the back of that, you're obviously going to get a whole heap of other objectives, but the main focus off that is to define the types of risk assessment or the types of questioning to risk assess those different areas. Because again, I don't think you'll get necessarily a catch-all, because you look at risk assessment, a good example is like a recent one, CCTV, and then thermal imaging CCTV. You've got a risk assessment which covers one for all at the moment because you've got the guidelines that come into that. But ultimately with the thermal imaging, which everyone's pushing down now with COVID, you've got a whole different risk assessment that needs to be created and guidelines that need to be followed because it's a different level of data that you're now capturing. So I think what we need to do is maybe once we define those buckets, so after this meeting, we'll hopefully some of you guys can get together and we can kind of start defining those buckets. And then we can start defining those risk assessment, almost the line of questioning that comes down to that. And that can be then implanted onto a paper that essentially becomes a risk assessment framework that we all abide to. And all of a sudden the paper starts getting a little bit of weight and coming back to that line of question of hovering that bit of paper in front of IT, you're providing a bit of education back to Trust IT that says, what is CE marking? Why? Because that's going to come against in the risk assessment, isn't it? It's going to be asked what level of CE marking is that product. And then we can see where that comes into and see what scoring and see whether it poses any relevance. I think that seems like a game plan, doesn't it?
Agree. Yeah.
Yeah. Awesome. Okay. So, is that everything, Craig, from Group 2? Sorry, I just saw you mute yourself.
Yeah, pretty much. I think unless anyone else thinks I've missed something, I don't think I have.
Awesome. Okay. Group 3. Should I nominate myself, guys? We'll do that.
Go, Matt.
I feel like I've talked enough. Essentially, I didn't even put it on the spreadsheet. I should put it on the spreadsheet. I think we came out to pretty much almost the same across all 3. The questionings were very overlaps, but we come on to the the question 3, and it's very much similar to what you guys have as outputs. We came up with a guidance paper. So again, I'll just remind you of the question: how do we improve contractual accuracy when it comes to Windows operating system upgrades and maintenance? Now, Group 1 touched on this anyway as an alignment process anyway. Ultimately, you need a guidance paper regarding lifecycle and how this relates back to the CE marking, which again touches on what we just talked about in Group 2. Believe it or not, isn't it really? I think it's all a harmonized approach where if we get this risk assessment defined, within that, you're going to educate our customers and our clientele across the healthcare sector, not just the NHS, about what CE marking actually is, because let's face it, a lot of them don't understand on an IT level what CE marking is. I certainly didn't when I came into the medical sector. I had no idea what it was and what its importance was. And I think IT back 5 years ago wasn't really thought about it as part of the CE marking anyway. It's only recently that it started to be looked at as a piece of software. And I think the key thing what we need to do is define what's in scope and out of scope. So you go back to a non-connected operating system, not connected to the network. Behind it's just an isolated standalone system, doesn't have USBs enabled, etc. All of a sudden, for an NHS trust, you've defined that as outside of scope when it comes to testing on Cyber Essentials. Therefore, they don't have to define it. Therefore, there's no risk to IT to fail the examination process, as it were. So I think it's very clear as part of our risk assessment. I think we can probably make it so that we can define what is out of scope, what is low risk and therefore out of scope, and medium risk and above is within scope. The luxury of risk assessments. Cool. All right. Well, I think that was good. The final thing is we need to start thinking about, and I think this is just food for thought really at the moment. I haven't got any answers to this, but I mentioned it earlier is kind of how do we measure success on these things once we start building them? And I think what we need to think about is when we're coming up with these outputs is how do we evaluate it? How do we come back and actually say, this has actually had a massive improvement on our processes and procedure, etc. And I think it was Daniel that said it, you don't know, it's time. Ultimately, it's going to be time that defines what that looks like. And it's going to be a 6-month, 12-month timeline for these types of changes, if not longer, especially knowing the healthcare sector. But I'm hoping with the rapid changes we're seeing with COVID-19 at the moment, we'll be able to measure success quicker than we would normally have done if this hadn't have happened. Not that I wanted COVID-19 to happen. Let's wipe that out of the recording for now. Okay.
I think you will, Matt. I mean, it feeds back into what I presented at the very beginning, that the acceptance of accelerated innovation in e-health is possible right now. And I think one of the challenges for us maybe is as a group, as a market sector, maybe as a broader sector in terms of healthcare suppliers, is we have to make sure that our innovation can continue to be accepted after this stops, because what will happen is we'll suddenly get a depowering of the acceleration of approvals and acceptance of stuff, because we'll shift back to, and everyone keeps talking about the new normal. You know, we need to make sure that there is a new normal for this kind of acceleration and the excitement about innovation, innovative products. Otherwise, we'll slip back to what we always did, and we'll just get what we always got.
I so promised Craig that I wouldn't say new normal as part of this presentation. You failed.
I didn't make it.
We all have to take a shot now. If this was a really bad drinking game, it'd be awful. These are unprecedented times. We might as well just top it off, you know, just to say.
The better normal, should put it that way.
Awesome. Okay, so what I'll do is, a part of that, we'll use that spreadsheet as a working sheet, as long as everyone's okay with that. You guys all have the link now. I think what we'll do is provide your feedback as part of that. You can't break it, so just add your input, and I'll review it regularly, and we'll bring it as part of the agenda for the next meeting. What we'll do is I might get in touch. Daniel, obviously you touched on the risk assessment element and the buckets. What we might do is maybe touch upon that outside of this offline, and we'll start trying to put together something that we start capturing that information. And I think if everybody can give their inputs as to what that potentially looks like, we may well have more than 4 than what Daniel said. But what we can do is they probably all link together anyway, and we might end up with 4 in the end anyway. So I think we can have everybody's input on it, because what's relevant to a larger based company might not be relevant to a smaller based company, and there's so many different variables across our IVD market. All right, so finally that takes us on to speakers. Now, obviously, we talked about a breadth of topics today. So it'd be interesting to know, I mean, like myself and Craig, we have an idea of speakers. but we didn't want to just invite speakers just to talk about a generic subject, which prompts more objectives that we can't get done, and etc. Didn't want not to sound negative, but you could end up with 50 to 100 more objectives, and you want to prompt thought at the same time. But so we want relevance with the speakers. So the question out there, and I'm just going to throw it out to the table really, does anybody have any wants or needs with speakers, or does anybody know anybody that would be good and relevant for this space? And if we don't get anybody with the answer now, what we'll do is we'll put something on the spreadsheet again, and if anybody comes up with a good contact over their working period and someone seems interested to get involved, I think what we do is we put those details on there. Don't put too much GDPR, don't put too many details on there, obviously. Not without their permission anyway. And we can go from there and just contact them, or you guys can make direct contact with them and we can bring them in for the next meeting. Does that sound like a plan?
Yep.
Yeah.
And there's no limitations to suggestions here. I mean, it really is open, and we don't know what issues or interests each company has. It's party to this. I mean, I've got a perspective. Some may be company interests, some may be self-interest, some might be something I've done a while ago and I thought might be relevant. Matt might be similar, but somebody else might have something. In terms of the knowledge base in this group, it's vast and different by person to person, and you might have something which is an interest to you or your company, or a challenge you're facing, or somebody that could maybe solve that challenge that some of us don't even know is an issue. We talked about stuff today, and a few of us have commented to each other that parts of the conversation go right over some people's heads. And that's just a fact in any working party. Everyone's got a breadth of expertise. So if you've got a particular interest that you would like to, feels like kind of show and tell, doesn't it, the US? But if you've got something you want to share or you think's of interest or of value, then by all means raise it. There's no hard and fast rules with this.
I think from my selfish perspective, I think what I'd like to see is maybe a speaker in the LAS market, Clinisys, Roche. That element. I mean, okay, so they're not LAS, but CITM. Someone related to those systems and their troubles and their struggles. Do they come up with the same sort of stuff as ours? Clinisys, TD, Technidata and all that kind of stuff. It'd be interesting to see what their. I mean, we touched on this at one of the first meetings, Craig, didn't we, about getting them involved in these chats, and I think it'd be quite good, maybe in a speaker capacity initially, but then maybe coming along to some of the meetings to help feed back into some of our points. So that they can either tag along, or it helps drive their position in the market, which therefore helps strengthen our case back to Trust IT and their IT departments. So.
Food for thought. This is often fun. We had one of these at one of the procurement working parties, one of the last ones we did face-to-face before everything had to go virtual, was we had two framework operators come in. It was the SBS framework and the NHS supply chain framework. Effectively, it's the same things being offered, but from different perspectives. And what you just mentioned there, Matt, was interesting. You talked about LAS and CITM. Now, to me, they're two different things.
They are two different things.
A data manager but commercially, you see, they're positioned. Sometimes the two types of options are positioned almost to do the same job. It'd be nice to have like two perspectives on the same topic from the same speakers at the same time, which would be quite nice. So if you had somebody maybe who is an LAS company, and then somebody who does LAS integration maybe from a trust perspective, then we can almost kind of get a commercial presentation on something from a provider, and then an operational perspective from somebody who's involved in it might be quite nice. So sometimes we can join the two speakers together if we've got a couple.
It would be awesome to get like a workflow chat, wouldn't it? Almost a Trust IT person who chats and sees it from his perspective. You then got the LIS person sees it from his perspective. You then got the secondary contract and people that interface to those areas from their perspective, and you understand the contract change and the assessments they have to go through and the line of questioning they go through.
For me, I think a trust integration engine.
Yeah.
The day is visibility on everything around at the moment. Now I'd like to get information above them to figure out what's going on there. That's my someone who works, because was it Microsoft have an integration engine they use, BizWiz or something like that.
Yeah, it covers like InterSystems, if they've used Ensemble and that sort of thing. Orion's another one, I think. Those sort of companies.
Loads of these companies there, and I'd really like to hear from these sort of integration engine companies, because these are talking about APIs. I'm talking about HL7 standardization. But again, that works great for hospitals, but doesn't necessarily work great for research and things like that. But again, that's my personal.
No, I mean, I think this is an opportunity to be selfish at the end of the day. It is. I mean, ultimately, getting a speaker in, you're never gonna. It's never going to be relevant for 100% of the people. We try and make it and try and make the whole meeting about 100% of the people and include everybody and make sure there's relevant points discussed. But I think a speaker is always going to tackle one particular pain point. So I think at this point we need to be selfish about it. And anybody you think that'd be really handy to get in that's relevant in this space, I'll put a worksheet up on that spreadsheet if you guys want to input on that, and just provide a company name or something like that that gives us some details about what the subject would be as well. That'd be really helpful. And then we can look to get them in for the timelines for the next meetings and so on and so forth.
Mm-hmm. I also wanted to add that during the last meeting, there was also a question to ask somebody with relation to the IVDR, because there were a lot of questions. And our RA manager, she is very willing to come. She did ask if we could then provide a list of questions. So maybe this is not something for the next meeting, but the next meeting we can think of the questions that we want to see for the IVDR and have her come after that.
Yeah, that's fine. I watched that webinar actually. So she was very good. So it's just a case of drumming up some questions. And did she say that she'd come on this webinar, or was it a case of she'd answer the questions?
She's willing to join one of our meetings, but she just likes to prepare beforehand. So if we have some specific questions, then.
So you're thinking more like an IVDR Q&A?
Yeah.
We'll call it Q&A. What was the name again?
Nele Ooms.
N-A-Y?
No, N-E-L-E.
N-E-L-E. And surname? O-O-M-S. Perfect. I might get in contact with you after this, Nadia, so we can get some contact details put around. And we'll send around a communication via that, guys, just to kind of, if we go that route for the next meeting, if it's useful for everybody, we'll capture some Q&A. Which is relevant to that, because I think it's going to creep up on us the IVDR, isn't it? So all of this happening, it's going to all of a sudden be 2022. I can assure you, and it's going to be a case of what do we do about the software element to it and standardization? And what's it asking us for? There's been a few revisions, I think. It's probably noted. You guys have probably seen it. I think there's been a few updates on the paper, hasn't there, for IVDR as a software? That element of it, I think, has been updated a few times recently. So it might be worth touching base again to see the updates on that element. But hopefully our standardization of digital requirements should come off the back of that anyway. I think we should really complement it rather than fight against it at the end of the day. It's a bigger governing body. So awesome. Okay, I think that's pretty much it, guys. So I thank you all for your attention. Appreciate your time. Thank you for joining us. I hope it was useful. And then, yeah, if there's any questions, please feel free to direct them either directly to myself or through Nat, and Nat will get them to me either way. And yeah, thank you very much. Appreciate your time.
Thank you.
Thank you.
Thanks, guys.
Bye.
Thank you.
Take care.
Thanks, everyone. Cheers.
Thanks, Matt.
See you later.